में जीबी ब्रिस्बेन भाई स्टार्ट है
আচ্ছা এখানে দেখে আমার ফ্রেন্ড দেখা যায় রবি দেখো আসো এটা রবি আঙ্কেল দেখো আর দেখে যা আর রবি আঙ্কেল দেখা কর রবি আঙ্কেল বলো হাই বলো এদিকে এদিকে আসো দেখতে
हाय
দেখতে পাচ্ছিস না দেখ এদিকে এদিকে এদিকে
हाँ
দেখ মাথা
हाय
নিচে কর মাথা নিচে কর
तार मस्त हेयर है जी
হ্যাঁ আমি তো তোর হেয়ার দেখে ডাকলি আঙ্কেল হেয়ার দেখেছো না রাসেল রাসেল দেখো দেখ 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 আচ্ছা চার্জার দিচ্ছি হ্যাঁ তারপরে নেক্সট জানুয়ারিতে আছে ইমিউনো অনকোলজি এথর
जानवर रे
হ্যাঁ ইস্ট সব গুড়া পড়ি যাইছি তো এথর
पार्टी तमे बुझलो तमे नेक्स्ट पूर्वेश्वर हवा जाउछु बोधे
ওকে আর কেতে দিন প্র্যাকটিস করি হয়ে গেল না বহুত বার্নড আউট হয়ে গেলেনি
बर्नट आउट
ଏବେ ବି ଦେଖୁନ ଏବେ ବି ଆସିଲି ହସ୍ପିଟାଲରୁ ଏବେ ବି 20-25 ପେସେଣ୍ଟ ଆଭଏଡ କରୁଛି କଣ କେତେ ଦେଖିବି କଣ ସରୁନି ରାତି 9ଟା 9-10ଟା ପର୍ଯ୍ୟନ୍ତ ଏମିତି ଚାଲିଥିବ ହେଇଗଲାଣି ଏ ଗଭର୍ଣ୍ଣମେଣ୍ଟ ହସ୍ପିଟାଲ ଭଳିଆ ହେଲାଣି এই যে গভর্নমেন্ট কার্ড গুলা হওয়া পরে বিএসকে হওয়া পরে সো ই এভরি হসপিটাল এন্ড এভরি ডক্টর হ্যাজ এন নম্বর অফ পেশেন্টস সরুনি ସବୁ ସବୁ স্লিপার সেল ভଳିଆ ଥିଲେ ସବୁ এই যে গভর্নমেন্ট কার্ড হওয়া পরে ସେ ସବୁ ବାହାରି ଆସିଛନ୍ତି ସବୁ ଏକ୍ସପୋ
अबे शेयर स्क्रीन टा कार श्रावणी रे अछि ना बे आई कैन नॉट शेयर
Shravani, could you please stop sharing the screen just for a moment?
Yes, 1 minute.
Yes.
Sir, you can now try sharing your screen, sir.
let me see
it's already 31
is it seen
yeah
okay then I'll just I can stop it because after yesterday's glitch I'm a bit stressed whether it will come or not
nervous तुम पार्टनर काली जॉइन करियो ना आज जॉइन करछि के ना
आज ही जॉइन करछि ना से कोन मेसेज लिखि छी ना
हां कोन लिखितला लिंक हेई पनी ना कोन
हां समथिंग लिखि छी से समथिंग लिखला मु देखली से देन ही सेड
नेक्स्ट टाइम किरण को भी ऐड कर दबा सो
हां
इंटरनेशनल फैकल्टी मु देई दिछि ना हाइलाइट्स ऑफ इंटरनेशनल फैकल्टी
oh my god
so Dr. Garima is the youngest surgical oncologist
oh I never met her
Namaskar, sir.
Namaste.
Good evening, sir. Good evening.
Good evening. Where are you from, Karima?
Sir, from Bhubaneswar, sir. Cuttack only.
Bhubaneswar, Cuttack only.
ससुराल है मायके है दोनों है
ससुराल मायके सब Cuttack and I'm working in Bhubaneswar, so all the places.
Okay. So you're working in Apollo, is it?
Right now, Apollo, right? So, yes, sir.
And you did your surgical oncology from?
Vaidehi, sir. Vaidehi, Bangalore.
Oh, Vaidehi. Ketol start? What time is it supposed to start? 5, isn't it?
Another 5 minutes, yes, sir.
5 minutes. So how's the work in Apollo? Busy.
So decent, sir. Pretty good. Yes, sir. Busy,
Yeah.
of course.
Mm.
Decent overall. Tumor boards are there: medical oncology, surgical oncology, and radiation. So we
Oh,
are able to do
Saurav
decent work.
joined back, is it? Saurav joined back.
Saurav sir was supposed to join back. He's not yet joined. I think he's there. He'll be telling us better
Oh,
about the timeline.
maybe today he will tell. Open it.
Right, sir, right. ठीक है सर. ମୁଁ ମନା କରୁଛି तो बंद कर बाहर को जाइए.
Hello, Garima. How are you?
Good evening, sir. Good, sir. How are you, sir?
I'm good.
So
कोई
when are you
नहीं.
joining, sir? Abhi Ravi sir was asking.
Hello,
You are
Ravi
joining by
भाई.
हाय केबे जॉइन करछु भाई अपोलो तमे.
भाई ମୁଁ ଟିକେ डाइसी सिचुएशन रे ଅଛି मते एम्स रे बड़ असुविधा.
काई कोण हेगला.
तू चिंता करना रवि आसी जॉइन कर जिवो तो
माने भाई हमर जो थिला मो जूनियर से छाड़ देई पळे गला.
हाँ सेटा तो मु जानथिले से आई थिंक से गोटे चैट रे मु आई कुड सेंस दैट शी इज लीविंग.
So basically एबे कोन होची जो I am the only person if I go so the department closes. बुझि पल्ले. तो सेति ପାଇଁ ଟିକେ ଗୁଁ ପୁଁ होचन समस्ते देखिया भाई आई एम स्टिल अपेक्षा ही करछि हम. आपण केमति अछन भाई ऑल गुड.
ऑल गुड चलचे समझे.
आपण आसुनांदी बोधे ना आसंती मझिरे
मु
मझिरे.
मु आस्छि मु विश्वास को देखा होची तते देखा होनी तू तो बिजी रहउछु.
ନାଇଁ ନାଇଁ ଭାଇ ସେମିତି ନାଇଁ. ଆପଣ ଆସୁଛନ୍ତି ଘନଶ୍ୟାମ ଭାଇ କୁ ଦେଖା କରିବା ପାଇଁ ହେଲା.
नहीं घनश्याम ने मु इवन सरोज भाई को भी देखा थी लास्ट गली बहुत बिजी बेताऊ से एरिया.
माने
सो
एबे तो सरोज भाई को देखा करले एते अपॉइंटमेंट नवा पड़िबो ना.
हाँ भाई पॉलिटिशियन लोग
माने टू टेक एन ऑफिशियल अपॉइंटमेंट otherwise nahi.
Not only by say resign कर दे चंदी वाली सुनिली, but I don't know ये ता ticket
Is it really?
ticket by
Ah,
मिलचे ना जाना नहीं,
BJD
किंतु
में ଠିଆ
resign
ହେଇଛନ୍ତି
कर
ନା।
चंदी काहीं करती है mostly मिली थी वाली करती है
Oh, is it? Oh.
So it's 5, we'll start.
I think so.
Absolutely. So already
Anshul bhai,
77,
I
77.
think you should start.
yeah.
It is late for me.
Uh, what is the time there?
7:30.
Oh, अरे बाप रे.
चंद्रकांत रो भी मीटिंग अच्छी एटी भागी की दौड़ी की जीव मार्क मीटिंग रे मैंने So Anita,
So we'll start.
Shravani,
Yes, sir, we can start, sir.
so you give us the no.
Go ahead, green signal.
Go ahead, signal.
Yes, good evening, sir. We can start the webinars for the day, sir.
A very good evening, everybody. I am Dr. Garima Saraugi. So first, I would like to introduce our program director, Dr. Saurav Kumar Mishra. He's medical oncologist at AIIMS Bhubaneswar. Our organizing secretary is Dr. Ghanshyam Biswas. He is the head of the department of medical oncology and clinical oncologist at Sparsh, and some hospital he's the professor. And Dr. Ravi Shekhar Patnaik, sir, he's from Brunei. He's the scientific chairperson for the day. Sir, first of all, I'll like to invite Dr. Ghanshyam Biswas sir to introduce in the context and the settings of this ceremony today. Thank you so much, sir.
So thank you, Garima, and a very good evening. So we are at 99. So that's a good number. So with one, so it will be a 3 numbers. So Ravi is there, is a good friend of mine from school days, and Saurabh and many others today. So we are into the third oncology update 2024. So every 3 to 4 months, we choose 2 themes, and Friday and Saturday for 4 hours like this year. So, and this webinar will be a breast today, and tomorrow from 5 to 9 p.m. we'll have lung cancer. So we'll have keynote speakers, we have discussions, panel discussions, we have even debates and also interesting quiz. To set the ball rolling, so we'll start with quiz. So this will have 5 questions. So you'll have 30 seconds to answer. So you have to write the answer in the chat box. So whoever's answer is right, so they will be awarded a cash prize. So once the meeting is over, and the best answer or the right answer and the fastest answer will be awarded. And so this whole meeting is about the updates in the international scenario of breast cancer. We know that the ASCO, the ESMO, the San Antonio, and now again this year 2024 ASCO is almost nearing in May 31st. So we'll start with our Dr. Saurabh Mishra, who is the program director for the day. So he'll start with the quiz. So over to Dr. Saurabh.
Thank you. So can you please share the slide text? Yeah, okay. Second slide, make it full screen and please, yeah. So question number 1 is, what is common to these 3 researchers? Start. You just have to write down what is common to them. So whatever you feel common, I mean, they are bald or they are British or they are white, whatever, leaving that aside. Okay, breast cancer, HER2 positive breast cancer, HER2 something more positive, something more specific. What is common? Yeah, I think they are getting the answers. HER2 is okay, but beyond that, something we need. Yes, that's it. I think the final answer has been by Ravi Bhai. So basically, all 3 of them were involved with research, discovery, development of trastuzumab. Dennis Slaman was the clinical trialist. Michael Shepard, he was the with the Genentech, the pharma, and here the research Max Planck Institute, Axel Ulrich. Next slide. So this is the next question, which is true about CDK inhibitors. So you have to find out which is the true statement. Both ribociclib and abemaciclib improve overall survival in the first line, that is in combination with letrozole. CDK inhibitors inhibit the transition between G2 to M phase in cell cycle. Abemaciclib has the maximum inhibition of CDK4, and Mona Lisa 2 and 7 mainly included endocrine resistant patients. I think the time should have been started. So what I would suggest is that as soon as we display the slide, you can start the time, although answers have been given already, but we'll wait till the completion of time. So we have to find out of these four, only one statement is true, rest all others are false. I think most of them have answered it correctly. The correct answer is here. Abemaciclib has the maximum inhibition for CDK4. You know, these are CDK4 and 6 inhibitors, but the maximum affinity and inhibition is by abemaciclib, more than ribociclib, more than palbociclib. CDK6 is less. And both ribociclib, abemaciclib improve OS in first line. That is not correct. In fact, abema doesn't have a statistically improved overall survival. Only ribociclib has. Now, CDK inhibitors, they inhibit the transition between G1 to S, not G2 to M. And the Mona Lisa 2 and Mona Lisa 7 were mainly in for the endocrine sensitive patients, not endocrine resistant. So correct answer is 3. So the answer, next question. So question number 3 is what is time start? What is DXD in trastuzumab DXD? And what is the mechanism of DXD? So basically you have to write down what does DXD stand for and what is it, means how does it act. Those two things have to be written. Perfect. I think we have got some good answers here. Yes, some good answers here. Yes, 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 fine. So I think the correct answer is given already. So deruxtecan and topoisomerase 1 inhibitor is the correct answer. Next question. So question number 4 is what is true about metastatic TNBC? So we have to say what is true. So all 3 are or 4 are there. Which one is the correct statement? Pembrolizumab platform SP142. BRCA2 mutations are more common. Combination chemotherapy improves overall survival compared to single agent. Sacituzumab govitecan improves OS in later lines. Perfect. The correct answer is actually 4. So combination chemotherapy. So sacituzumab after 2 to 3 lines of chemotherapy in TNBC, TROP2 inhibitor, and it can improve OS and PFS. And the combination chemotherapy only useful in those very symptomatic. Otherwise, there is no improvement in OS compared to single agent. BRCA1 mutations are more common. Platform for pembrolizumab is 22C3 farm DX depo. Thank you. Next question. So correct answer is 4. So this is the last question. Identify her. Who is she? You just have to write down. You have a hint over there. So what's her name? Angelina Jolie, is it? Perfect. Chandrakant is always there to answer first. Most of the time he gets awards also. Angelina Jolie is something different. So anything related to breast has to be Angelina. Is it Ghanshyam bhai? So basically, she is not Angelina Jolie. She is Barbara Bradfield. She was the first lady to receive trastuzumab. So the Genentech trastuzumab, which was developed by these researchers, and she went on to receive trastuzumab for 25 years. So she is the first lady to receive trastuzumab molecule. Thank you.
Thank you so much.
Thank you so much, sir. Wonderful quiz.
Thank you.
I think by the end of 1 or 2 sessions, we will get the answers who are the winners for the quiz as well. So we'll move ahead to the first talk of the day, that is on metastatic hormone receptors, positive breast cancer, putting the best foot forward. And now welcome Dr. Ravi Shekhar Patnaik, sir, to take over. I request sir to maintain the timelines. Could you?
I
Hello,
cannot
sir.
start my screen.
Sir. Over to you, sir. Anita, can you please start Ravi sir's screen?
Sir, you can start. You can share your slides, sir.
Okay. Is it visible?
Not yet.
Not yet, sir.
Is it? No.
Not yet, sir.
Sir, with your permission, can we share it from our end, sir?
Yeah, can. No problem.
Yeah, thank you, sir. I'm sharing it.
Hi, good evening, everyone. It's a pleasure to be at least virtually with my fellow brothers and colleagues out over there. And thank you, Biswas, for this invite, and Saurav. I'm glad to see Garima here as a surgical oncologist. Um, so the first topic to start with is like a metastatic HR positive, HER2 negative breast cancer, putting the best foot forward. It's actually a very double-edged sword topic because the time is so limited, and maybe 10 years back, I would have got ample time, 15 minutes to talk only about aromatase inhibitors and tamoxifen. But now, the last 5 years, it has seen a sea of change in the whole treatment in advanced breast cancer, hormone positive. So can I have the next slide, please? So if we look at in 1975 to 1995 was the period when we were talking about tamoxifen. And gradually, if you look at from 2015 onwards to 2023, end of 2023, in fact, we got 3 more drugs already approved at this period, 2023. We saw a sea of change of new drugs which has come in, which includes from aromatase inhibitors to SERDs to CDK4/6. I think the main child is the CDK4/6, which we all dwell upon in advanced breast cancer, hormone positive. We can say it's the poster child for advanced breast cancer now. And we have some of the new drugs, which some are very toxic, some are drugs which is not available to the most of the people, and some drugs we just read about it. So let's go through all these things in these few minutes which I get. I will just touch upon superficially. I won't go deep into the trials and settings in respect to the time. Next slide, please. So if we see actually the first of the, can I see the, I see it is very much truncated. I don't see the whole slide. So the first thing which we see mostly is the Mona Lisa 2, which has been, as Saurav has spoken about, that was the first of the CDK4/6 which showed an overall survival benefit, which showed in an endocrine sensitive tumor when you are giving an AI with an CDK4/6, which is ribociclib. It really produces an 5-year survival. Actually, you look at an overall survival of around 60 months, which is nearly 5 years. Some of our patients are still around more than 5 years now, which has actually shown an hazard HR of 0.76. So this is the first of the drug which got in both ESMO from NCCN. Everyone gave a thumbs up for this drug for being giving this benefit. So the next drug, which was initially, can I have the next slide? So the initial CDK4/6, which most of us have been using earlier, was by this Paloma trial where they gave palbociclib, which unfortunately, recently the JCO has come out with this article showing that it did not live up to the secondary endpoint of median overall survival. There was no benefit of giving palbo plus letro, let in view with the placebo with let. So the palbo arm did not show much benefit. If you look at the overall survival was 53.9 months, and then you have the placebo arm with only let is 51 months. So there was hardly any difference, and the hazard ratio was 0.9. And if you really look at one, the author is Dr. Dennis Lemon, in fact, the one which Saurav showed in Herceptin um, quiz. So he put it this in recently in this article that unfortunately, Palbo did not live up to the mark. But if you look at in the real world data, doesn't show the same what the trial shows. Most of the world now still they hang around with Palbo because it has been long time, and most of my friends have been using it. So they are quite comfortable, and most of the people are aware of it. So sometimes real world evidence and real world data and the trial settings may be a little bit different, and we have to look at according to the logistics and according to the local. So next slide. Next slide, please. So the last of the drug which came in was the Abima. Unfortunately, I won't be talking about the drug which was also the Chinese drug, which is daplisiclib. I think it was the trial of Dawn 1 and Dawn 2, I think. So I'm not going to talk about it. I'm talking about abemaciclib, which was the last of the drug, which also, if you see, this is a CDK4/6, which has a wide blockade. It can work at CDK4, CDK6, CDK9, CDK2, multiple levels it works. So its side effects are a bit different than the usual one, and it showed somewhat an overall survival benefit compared to if you look at to the placebo arm. And one of the good point of this drug was that so-called CNS penetration with this drug. And this drug also had this benefit of being used as a single agent also. So if you look at, it showed an overall survival of 67 months compared to the placebo, which was 54 months. Next slide, please. So if we look at all the trials, the Monarch, which was mostly Abima, Monarch 3 and Monarch 2, the Paloma 2 and 3, Mona Lisa 2, 3, and 7. Most of them showed an overall survival something around 50 to 60 months. So now is a period when we are seeing that the survival has jumped from what it was from the era of tamoxifen and aromatase inhibitors, when we were looking at a median survival of 2 years. Now we are looking at an overall survival which is touching around 5 years compared to if you look at most of the arms, you would see that something around there is a big difference between 54 to 67 months, and people have been taking it. How it is beneficial, we will come. There have been some we have to take with a pinch of salt. If you look at the Sonia trial, which did not show a great benefit of using upfront CDK4/6, rather they would say that CDK4/6 should be used on the second rather than on first. But then the CDK4/6 which was used there was Palbo. So probably that was one of the reasons why that trial did not live up to the live up to what we are looking at with other CDK4/6. So next slide, please. So if we look at now, I try to put all the CDK4/6 into one. The one which Saurav said is endocrine sensitive, endocrine resistant, and if they have taken prior chemotherapy. So this is the one which I was talking about. In Monarch 1, they took people who took even chemotherapy and they were given a single agent. Now endocrine sensitive, if you look at Abima with AI, I will talk about what is primary resistance, prime and secondary resistance. So endocrine sensitive, we are looking at here, and in Paloma 2, you have Palbo with an AI. In Mona Lisa 2, you have Ribo with AI. Don't ask me why Monarch 3 is Abima and AI, and Monarch 2 is totally different. And Monarch 2 is something where Abima and fulvestrant, where everything is 2, 3, it goes like this. Here it comes 3, 2. And Paloma 3 is Palbo with fulvestrant. And Mona Lisa 7, if you look at it, contains ribo with this looks only at the premenopausal patients. The fourth CDK4/6, which I was talking about, is this dalpisiclib, which is a Chinese drug, which was done by the two trials, which was Donna 2 and Donna 1. Although their OS is immature, but they did show a PFS benefit. So if you look at the PFS was 30 months in the first endocrine sensitive. When you add on with CDK4/6, it increase another 20 months. So roughly you are looking at the total of 53 to 67 months. If you look at the journey of an metastatic hormone positive patient goes around up to 60 months with this sequencing, what we are looking at. So all that doesn't always hold good. This is all what we see in pen and paper, but a patient may have a different other story. The biology may be different. So let's look at how things move forward. Next slide, please. So I just want to show you that all the NCC and ESMO, everyone has put in the first line has been aromatase inhibitor with CDK4/6. Aromatase, and this is for the first, if they have not taken an endocrine. If they have taken an endocrine, then you change it to a fulvestrant in the second setting. In the second line, you are looking at fulvestrant with CDK4/6. So if you have got a mutation with EPIC3 or AKT in a second line, you have other drugs, which I will talk about in the next slides. And there are also some of the other things which we are looking at, and ESR1, if there are. So we have some blockers and oral SERDs, which we can give. Now we are also looking at HER2 low, where we can give some of the drugs which Durexitin, which we talked about. So then there is also some of the drugs which, like, even you can go with immunotherapy for these patients and PARP inhibitors for these patients, depending on what is their molecular profile says. So that is what we are coming to. It is not all patients are created same. So they are being differed by their molecular levels. So not all hormone positive tumors should be treated the same. They may change. Maybe the first line may be the same, but from the second line, it goes on changing what drugs you want to give, what drugs you want to change. Next slide, please. So it's the same. If we look at, if you are having a BRCA mutation, maybe you are looking at, if they are not in a visceral crisis, you are looking at giving a PARP inhibitor. If there are no germline mutation, then you are going with an systemic therapy. Second line, you are looking at, if it is an HER2 low, then you are looking at Durexitin. If it is an HER2 low, HER2 zero, and patient has some ILD and other things which patient cannot take a Durexitin, then you have sacituzumab as a drug. I don't know how commonly it can be used. It's so pricey and so costly. I do think that when we look at in real world data, the drugs which we are talking about in the second and third line, it's quite pricey for us to go ahead and give. So there, the CDK4/6 and all these drugs beats through. And we are now looking at MSI, NTRK, RAT, PMB. If it is high, we have got targets targeting those things. Next slide, please. So what are the NGS which you are, what are the things which you are going to do? Now, HR positive, HER2 negative patient progressed after CDK4/6, you are doing an NGS and you found that it has got a PIK3C mutation. So the category 1 is an alpelisib with fulvestrant, which is there. Now, the same patients had an AKT mutation or PTEN mutation. Then we have this drug, which has recently been approved, which is called an capivasertib. The beauty of this drug is it doesn't look at how long the CDK4/6 was given. Because if you look at the oral SERDs, they want, the benefit comes only if the patient has taken for a year. But in capivasertib, they don't look at that. Now, if you have got an ESR1 mutation, which we are looking at. Now we also have to understand, previously ESR mutation we were looking at as fulvestrant, but not all ESR1 mutation will benefit with fulvestrant. So there is something which I try to make it a mnemonics because it's very difficult to remember, Y537S. So that can be something which we are looking at, they cannot respond to. I need 5 to 10 minutes because it's quite a big topic which Biswas gave me. Now,
So another 1 minute 35 seconds. Sir.
NTRK, we have entrectinib, then we have MSI high, we have got Pembro. Next slide, please. So this is possibly by the ESMO, if you look at, they also come up to the same thing, that the first line is in ET with CDK4/6, progressive disease, then you are looking at if there is a germline mutation BRCA2, then you are going with an or PALB2, then you are going with a PARP inhibitor. If there is a PIK3C mutation, then you are going with an alpelisib. It's the same thing which we are looking at in the first and second line. So if there is a crisis, you are going with a chemotherapy. If there is a progressive disease, then we are going to sacituzumab or duroxetine if it is an HER2 low. Next slide, please. I think this was the PAGA, which they also approved the same thing, the Pan-Asian breast one. They also agreed upon the same, what the general ESMO guideline was. So next slide. So what is a primary endocrine resistance? So if you are looking at this, is a very interesting thing. Can I see it, make it smaller, please, the slide? So if you are looking at a primary endocrine resistance, so it looks like the relapse while on the first 2 years on adjuvant endocrine therapy or progressive disease within first 6 months of first line of endocrine therapy for MBC. And secondary acquired endocrine resistance. That means you are acquiring these resistance because like you are getting ESR1 mutations and others. So this, they relapse within adjuvant endocrine therapy in the first 2 years. But after first 2 years, that means the patient has taken 2 years of endocrine therapy and then relapse. Or we are looking at a progressive disease more than 6 months after initiating endocrine. This is less than 6 months, that's more than 6 months. So this is very important to tailor your treatment, which one you want to give, whether you want to give a fulvestrant or whether you want to go with the same ET you want to add in or differ the ET. Next slide, please. Now the same thing can happen with
extra 2 minutes starting now, sir.
So
sorry to interrupt.
Sorry.
Sorry to interrupt. Times are up and extra 2 minutes we are giving, sir.
Okay, thanks. So I think I should be done within 2 minutes. So we are looking at and CDK4/6 inhibitors. So it's not always the endocrine resistance. You also have a CDK4/6 resistance also. Some of them is like an RB1 loss and FAT1 loss by Hippo pathway and the CCNE1 and FGFR amplification. These are all de novo resistance. That means you have given CDK4/6, but then the patient doesn't respond. So what is the reason for that? That is because they have these kind of mutations which we are looking at. Now, the same thing which we are looking at an acquired resistance, they can have an RB1 loss. And then there is something like which we are looking at HER2 or mutation, not the amplification. Here we are looking at a mutation. So our PTEN loss. So these can also happen in this kind of situation. So as Saurav already said, they work at G1 to S phase. So when you have these resistance, so obviously this is not working. The CDK4/6 is not working. So you have to target those which can affect this, and that can help out to circumvent these resistance out. Next slide, please. So this was the trial for alpelisib. Let me go next slide. So where we are looking at a PFS benefit of 39.3, the overall survival result which came out 39.3 months for alpelisib versus 31.4 months for the placebo arm, which we are looking at. So which was fulvestrant with a placebo. So, but it had its own problems. It had its own side effects, which we are looking at. So alpelisib, and it's the trial which we are looking at was SOLAR-1. There was also the other trial which was called BILIVE, where they wanted to give it later lines. Next slide, please. This was the first trial which actually showed the biggest hazard ratio difference. I remember when we were still in our new DM, we used to see that there was this big gap between the HR. This is the Bolero trial, which started with everolimus, which showed the first treatment which could overcome an endocrine resistance with exemestane. So those patients who actually were resistant to endocrine therapy, they were given everolimus with exemestane and showed a benefit of 7.4 months to 3.2 months. Next slide. Next slide, please. I won't go deep into this. This is the one which I talked about, AKT and PTEN mutation, which we are looking at. Next slide, please. So the PARP
So the
inhibitors,
time
which
is up,
was
sir.
Garima, 1 minute.
Yeah, sure, sir.
There are two trials which we are looking at, the Embarca and the Olympia trial. Both were looking at a PARP inhibitors. Both showed a PFS benefit in these patients. So this was also translated to, because they took not only TNBC, they also took hormone positive patients. And they actually responded with a benefit in PFS. So these can be tried as a second line. Now, those patients who had got a BRCA and had hormone positive, what do you do? Do you go with a CDK4/6 or do you go with an olaparib? So in a metastatic setup, the consensus is to go with an CDK4/6, then if progression, go with an PARP inhibitor. Next slide, please. Next slide. Next slide. Next. So the Emerald trial is the one which we talked about, as I talked about the oral cert. So if you look at, the benefit was mostly in ESR1 mutated and those who have taken CDK4/6 for 1 year. So if it is less than 6 months, they usually don't benefit with this drug. This also got recently approved. So this is one of the oral cert which can be of help for patients. Next slide. So what if we don't have anything? So sometimes we try to play with it like we used to do earlier. Okay, you gave an aromatase inhibitor, like let's say Arimidex, progressed, so you gave exemestane. The same way here they changed. They gave first Palbo in maintain trial, progressed, they gave Ribo. So this is something called beyond progression. You just shift the CDK4/6. So the maintain trial showed some benefit, but all these were phase 2 trials, the maintain pace and Palmyra. So I wouldn't go much into it. I would say that if there is no options left for you and patient is still good enough, you can still try keeping on a maintain therapy. Go ahead. Next, please.
So the timelines are a little tight. So
Last,
sorry to
last slide.
interrupt you again.
Destiny,
Sure.
Tropic, and Tropion. All these three, we can move. Next. Next. Yes. So can I go back? Yeah. So this is possibly the one which we were talking about. These are the three trials which we are looking at: the Tropion, Tropics, and Destiny. Of which Destiny Breast 4 was the one which we are looking at, and HER2 low. If these patients, when you find after chemotherapy, you find that they are HER2 low, you can think about Durexitan as one of the option, and it has given a big overall survival difference. Like if you look at 23.9 months versus 17.6, and sacituzumab also, the paper was recently out, that also showed a big difference, 15.5 versus 11.2 months. So these two drugs have an impact in our treatment for this. So the last slide is, this is possibly the approach which can I move next slide? So the first line should be an AI with CDK4/6, and then fulvestrant with CDK4/6. This could be your first line. The second line, if you have not given an fulvestrant, you go as a second line. If you have not given an AI, you go as an CDK4/6 as second line. If you have got a biomarkers like PIK3, BRCA, ESR1, or any of the AKT, you are looking at this drug. Then I would say that possibly the HER2 low will be the one which is coming in this line. So, and now that we are doing MSI high TMB, you can think about an IO. Still, eribulin still stays, because this is something as a poor man sacituzumab for me, because sacituzumab I cannot plan to give any patient. Maybe eribulin is cheaper and easier to give, and patient can afford that, or capecitabine or taxane. So chemotherapy still has an hold post 3 lines of treatment. Thank you. Sorry, I kept long, but it's a big topic.
Excellent. Thank you so much, sir. It was a wonderful and informative session. And I think everybody has summarized at least the basic of what you had to give the message. So we'll quickly move ahead to the debate for today. The debate is on adjuvant abemaciclib in high-risk hormone-positive breast cancer patients, for and against. For will be by Dr. M.V. Chandrakant, sir. Against will be by Dr. Amit Kumar Chaudhary from Lucknow, and expert opinion by Dr. Jogmaya Patnaik, madam. Jogmaya, madam, are you there?
Yes, she's there.
Okay,
we'll
so I'll
start.
start. Yeah, so I'll start
Yes.
then. Yeah. So I
So I
would thank.
request you to maintain the
Yeah,
timing.
yeah.
Yeah,
I'll
thank you.
maintain. Don't worry. Yeah. So I thank Ansham sir, and 177, 183 people listening to me. I mean, that's a privilege. So hardly I get 10 people listening to me. So, I would congratulate Dr. Ravi for his wonderful talk. And let me say in coming 2 minutes why I should use adjuvant abemaciclib in early breast cancer. So I will start my presentation with the straight back, telling what the facts are. So we all feel that ER positive breast cancer is good, but look at the 10-year chance of recurrence, 40% recur. It is much worse than triple negative breast cancer. If it is T3, T4 or N plus, four out of 10 patients do recur and die of breast cancer. So it is no longer a good disease, if you have a 10-year follow-up. So it's a bad disease. And we changed from tamoxifen to AI, not based on OS, based on a recurrence-free survival of a small 3.3%, not that much. So we have changed practice based on recurrence-free survival based on 3% difference. And here is the curve 5-year monarchy data of giving adjuvant abemaciclib for 2 years. You have a 7.6% difference in IDFS and a 6.7% difference in DRFS. And why are we not changing? That is the end of my presentation. I will have the climax after presentation from the other. Okay, over to you. I have 3 minutes left after you present. Dr. Amit.
Excellent. Chandrakant has saved 5 minutes, which was taken by Ravi Bhai.
No, I have 3 minutes rebuttal. So that's just my straight back. No, there is no need to come in later.
Good evening, sir.
Doctor.
Thanks a lot for
Yeah,
good evening, sir. Thanks a lot for giving me the privilege to be a part of the debate session. And after that Super 2020 match, I don't know whether mine will be 50-50 or something. So is my screen visible?
Yes, sir.
So quickly, I will just tell why we should not use Abema. So the real world evidence, if we see the Abema criteria, only 11 to 12% of the early breast cancer patients fit in the Abema criteria. If we see the basically the monarchy criteria, this was the real world experience from US, from the Dana-Farber Cancer Institute, where the around 4,500 patients were there, and they had seen that the criteria which the monarchy included, that means the hormone positive patients with node positive, only out of those patients, only 500 patients, that means the 11% patients were eligible for the abemaciclib. So my main question will be against the abemaciclib, whether the monarchy inclusion criteria is what footfall we are having in our OPD. How many patients are we going to see of the EBC who are node positive? Also, if we compare the Natalie inclusion criteria with the monarchy criteria, we can see Natalie is a more robust and means it is a more practical. They have included almost all the patients who are node positive as well as node negative, including stage 2A, 2B, 3A, 3B, and 3C. So there are many patients who were excluded in the monarchy criteria, and Natalie included those patients also. And nevertheless, we have seen that the Natalie data is also very, very satisfying, with the risk of the invasive disease reduced by 30% in stage 2 and 24% in stage 3. And in node negative patients, the risk of invasive disease was reduced by 27% as compared to 24% in node positive patients. The distance-free survival was also, it was DDFS was also positive with a hazard ratio of 0.74. The overall survival, we know it is a difficult thing for breast cancer patients. So safety profile also of the Rebo was very, very comparable. Means the safety profile, because they had used a reduced dose of 400 mg as compared to 600 mg, which is used in the advanced breast cancer patients. So this was very well tolerated. And why not? Ribociclib is a more better drug if we want to use in the EBC adjuvant setting as compared to the abemaciclib, because the monarchy data, the inclusion criteria is not something which is very, very, it is not including many patients which fall in our OPD which come to our OPD on a daily basis. Now, the second point is why we want to give extra pill also. Means if I tell कि मुझे अबीमा भी नहीं देना है, मुझे रिबो भी नहीं देना है, because the problem of poor adherence in the adjuvant is a big problem. There may be there have been studies which have shown that continuation rates and adherence has been a big problem in the ABC patients, and these things actually which are easily neglected in our OPD, and this lack of adherence leads to a this lack of adherence leads to the losing of the DFS, and there is a loss of the benefit of the drug. We know that if the patient don't comply with the consistency, and also we know that with the side effects in monarchy also the dose adjustments were made, and let's say for grade 2 diarrhea only, but grade 1 diarrhea, I'm sorry, but these side effects also can be a big problem. As we can see here, up to 80% of patients who experienced diarrhea in the clinical trial setting. But what about in the real world? It may be even higher. And why to expose to side effects when we don't have an OS data also? And if we see other side effects were also there, like neutropenia, which required the use of the growth factor along with severe fatigue. And even we have patients, around 3% of patients had ILD and pneumonitis in the abemaciclib. So post-COVID, if we are giving an additional lung toxicity to the patients, then I think we are going to harm the curative patients. So it is a big challenge when we don't have a very mature data in front of us. Also, the risk of VTE was increased if when abemaciclib was given. With the ET, it went up to 2.5%. So these were the few points, and let's not forget the overall survival data is still not there, and the cost of abemaciclib, we know that it is almost 69,000 in hospital setting, as well as if we purchase directly from the vendor, it will cost around I think around 50,000. So extra cost for 2 years, along with these side effects and along with the inclusion criteria of the monarchy, I think monarchy is not something which I will vouch for. Thank you.
Yeah, so I will just have a rebuttal for 3 minutes. So just stop sharing, Amit.
Yes, sir. Yes, sir.
Oh, it was very good. So he spoke, he wants to give CDK4. I thought he doesn't want to give CDK4. So that's a googly now. So, okay, next 3 minutes, let's see the climax, how it can be. So I was just writing the rebuttals for what Dr. Amit had spoken. 11 to 12% are the ones who qualify for monarchy. This is in Dana Farber with Diana, but we have Gauri, Fatima, and Lakshmi. They do not screen, they come with stage 3 disease. So for us, 40% patients qualify. So a big number. And Natalie, is fighting a legal suit. They cannot promote their drug right now in early breast cancer. Only the medical team is, they don't have a significant IDFS. If you look into the curves, they're just kissing on each other. And then you should not unnecessarily over-treat all T2N0 patients. And if they're toxic, both trials have 18% discontinuation, bang spot on. And Ribo doesn't work because, 3 weeks on, 1 week gap. So in that 1 week gap, the cells will multiply again, repopulation. VT is same in all the three that we know by meta-analysis. And cost, be careful, 60% required dose reduction, 200 milligram OD. Abima equals 400 milligram OD of Ribo. So, okay, so now let me come to why we should give CDK4. So these are my rebuttals, and this is the preclinical data saying that abemaciclib is the most potent. That was the MCQ by Dr. Saurav Mishra. Most potent CDK4. There is only one CDK4 inhibitor, that is abemaciclib. Rest all are CDK4 and 6 inhibitors. More of 6 inhibition is there. Therefore, one CDK4 inhibitor, that is abemaciclib, continues. That is the one that has shown. So no OS benefit, that doesn't matter. IDFS is a good endpoint. And then look at the reason, look at the data we have. You just show me the paper of Natalie. Do you have it? You don't have. Look at the curves. So though there are more patients living with disease than patients who are not living with disease. At 5 years, 121 versus 235, double the number of patients are having metastasis. I want to live without breast cancer. These are some criticisms they had, but you can see NCCN had A and level 1 rating by the international guidelines, and these are my conclusions. Adjuvant Abima improves IDFS, DRFS, OS immature, but it is likely to be positive. And then IDFS and DRFS are relevant endpoints and very important. Both category 1 recommendation, even 1 day of life without disease matters. Adjuvant Abima should be offered for all eligible patients. And Natalie is very premature, and I'm sure it will be a negative trial. They're trying to find out patients who are going to be eligible for it. They're fighting a legal case. So Amit, they're fighting a legal case already. So no worries. Thank you. So Jai Shri Ramivan. Thank you.
Thank you.
Thank you.
Thank you both Dr. Chandrakant and Dr. Amit. So nice presentation from both sides. CDK4/6 inhibitors are actually very important in the setting of breast cancer, both in adjuvant setting now when the data has come, and also in the metastatic setting, because they are oral drugs and they're actually super easy to give. They don't have much side effects. Abema actually does have some side effects like diarrhea. Definitely giving it in an adjuvant setting and improving the invasive disease-free survival looks very promising, and most likely it is going to improve the overall survival. But yes, we should be careful about whom to give it. In medical oncology, we always have a lot of drugs, but we have to decide whom to give it, whom not to give it, how to sequence it. Whether I will keep it in the first line or I will keep it for the second line or the later lines when the patient becomes metastatic. So that becomes a question. In that, I think in OPDs, we need to decide the proper patient. This is actually not for everybody. Definitely, as Dr. Amit has told, that in adjuvant setting, attrition rates, default rates, 2.5% VT, ILD chances, or these are actually difficult things to handle in adjuvant setting. When the patient thinks that I have been operated and my disease is cured. So Abima definitely is not for patients who are they are not compliant, and we think that they will not come for proper follow-up and they will not continue the treatment. But definitely good educated people who actually want to get a disease-free life, breast cancer-free life, Abima definitely is the answer for them.
So we still have time left, is
it? Yeah.
Okay.
But a wonderful presentation by both. And yes, sir.
So okay, so I think if there is time, some time left, so many people are there. I need to, if you give me 1 minute, I'll just say something from my end.
Definitely, sir. Definitely.
Breast cancer is one of the most common cancers. If I and anyone are diagnosed with breast cancer, we don't want the disease to come back. Okay. So I want to get it cured. If I have a disease back, my life is going to be hell. My mental condition is not going to be good. So I don't want the disease to come back. So we have to do something more than hormonal therapy. And Abima and Ribo is still immature to say right now. But the CDK4 inhibitor definitely have changed the landscape and has prevented the disease coming back for so many patients and has changed landscape. So we must counsel the patient that the chances of this is not coming back is this percent. And if you want it, then we must offer. If you're not offering CDK4 adjuvant, probably we are doing some inferior treatment, because this is the data we have. We cannot deprive patients of this excellent drug. Okay. And toxicity, that's fine. You take toxicity, 20% mortality. We still undergo transplant for that. But Abima, so we have not seen any mortality significantly. 18% discontinuation. That's fine. You are monitoring the patient. So I think we must offer these potential drugs, and the intent is cure. The moment the intent is cure, you need to accept the toxicities. You need to counsel the patient. Do not counsel the patient at the end of radiation. Counsel the patient at the beginning of chemotherapy itself. So these are my suggestions and viewpoints to all of them who are listening to me. Thank you.
Thank you, sir. Thank you, sir. But if we tell that huge cost at the beginning of the therapy, most of the patients then will do the medical shopping. Ultimately, they will.
you cannot hide the cost of drug. You need to tell the benefit to them, and it is there. And 60% dose reduction is there. So you need to be careful before you explain the cost, right? So that is or you have to counsel them properly. regarding this. Yeah.
But in curative setting, in adjuvant, sir, the main problem is if we try to explain that even 2-3% cases are there who may have a grade 4 toxicity. In those cases, it is very
You
difficult.
can stop it. You can stop it anyways, right? So you are monitoring those patients. I think we should offer in a curative setting very strongly. That is my feeling.
Okay.
If I am the patient, I want the drug.
Okay.
Thank you.
Yes, thank you. Any closing statement by Jogmaya, madam?
I think the drug is good and should be offered to eligible patients. We should decide in OPD who actually is a proper or eligible patient. I feel the drug is not for everybody. That is, cost is prohibitive, as you all know. Whoever can afford should be offered.
Right. Thank you so much. For this was a good thing. Two things to summarize here. As Dr. Chandrakant told, when it is available, we have to give the options and counsel the patients. And the selection criteria of the patient is very important. Thank you so much. A wonderful summary about amoeba-cycline. And then we'll quickly go to the, thank you so much, all the three of you. We'll quickly go to the next session, which is a panel discussion by Dr. Amish Vora. The panel discussion is on treatment sequencing in HER2-positive metastatic breast cancers. Amish sir is available. I think he will like to call upon his panelists. Jogmaya ma'am is already there. Amish sir, can you hear me?
Hi, everyone.
Hi, good evening, sir. Welcome, sir.
Good evening. Sorry, as usual, I thought my topic is at 6:40 and not 5:40. I checked it 2-3 times, and so you'll have to give me just 1-2 minutes. I'm just setting up my another laptop because this laptop, the PPT just goes blank.
So what we can do, Garima? So we can, if Dr. Kanu,
so we'll introduce the panel,
no,
sir.
No, if
okay, we'll.
Yeah,
we'll
please, if you can introduce the panel.
Okay. Gansham sir will do the next talk or will introduce the panel, sir?
No, if Kanu
please introduce the panel. I'll just.
You can declare the results, no, sir.
30 seconds.
Declare the results if in the meantime.
What is the price?
Yeah, price.
Cash
You
money,
will get
cash
new
money
car.
of 1,000 rupees.
You will get a new car for your answers. Correct answer. You needed a car. Garima will drive it.
Car?
So Saru sir will declare the results in the meanwhile. That will be a good thing. And then we'll introduce the panel. Sir,
I don't have the results. You guys must be having. I don't have the results.
Anita,
I think
do you have the results?
Just a second, ma'am. I'm sharing in a minute to you.
Otherwise, I can present after that. My talk is 15 minutes.
Achha.
Yes.
So I'll be ready now.
So Kanu sir.
I'm there.
So Garima, introduce the panel, no? So
yes, sir. I will introduce the panel in between. We'll go in the same sequence as decided. Yes. We are here about the panel discussion for treatment sequencing in HER2-positive metastatic breast cancer. Our moderator is Dr. Amish Vora, sir. I welcome the panelists, Dr. Jogmaya Patnaik.
Thank you, ma'am.
From Bhubaneswar, Dr. Debadullah Biswal from Raipur, Dr. Sthiti Das from Bhubaneswar, Dr. Madhuri Kavikondala from Hyderabad, Dr. Niharika Patnaik madam from Bhubaneswar, Dr. Sudatta Ray from Bhubaneswar.
Okay.
Do we have all our panelists?
Yeah. Can someone upgrade me or as a panelist on my another laptop?
Sure, sir. We will do that.
Yeah. Then I'm ready.
Hi Amish. So are you traveling tonight or not?
I'm traveling tonight at 10:30 p.m.
Okay. Sorry. So for me only you have to bother so much, no? Thank you for accepting.
Thank you so much, Amish sir.
So we have promoted you as a panelist, sir. You would have got the notification.
Anita, in the meanwhile, you can just assimilate the results.
Can I share my screen?
Yes, sir, you can.
So over to you.
So, is my screen visible?
Yes.
And I'm audible also, right?
Right.
Yes.
Okay, perfect. And how much time do I have in the panel?
30 minutes.
So 20.
Somebody said 20, somebody said 30.
No, 30 minutes.
30 minutes. Okay. So the timer is there. So we have all the panelists, if I understand correctly, we have Dr. Jogmaya Patnayak, and we have Dr. Debadullah Biswal. Can we have the panelists as, if they can switch on their video, it will make more sense. Dr. Jogmaya, are you there?
Yes, sir, I'm there. I'm there.
Okay, perfect. Dr. Debadullah? Do we have Dr. Debadullah Biswal?
He's there. His name is there, no? So, Debadullah.
Debadullah bhai, are you there? Please acknowledge.
Okay. If you can say hello.
I think, sir, he's
So you ask
muted
him
or
question, he will say.
So, Dr. Sthiti Das.
Very good evening, sir. I'm very much there. Good evening,
Perfect.
everyone.
Good evening, everyone. Then Dr. Madhuri Kaukondala.
Yeah, hi, I'm here. Thank you for inviting me.
Thank you, ma'am. Dr. Niharika Patnayak.
Hi, good evening. I'm here.
Good
Am
evening,
I?
ma'am.
Yeah.
And Dr. Sudatta Ray.
He's there. He's there.
Dr. Sudatta Ray, because we are starting from you. Can I say hello? Can I hear hi from Dr. Sudatta? So I have not heard from Dr. Debadullah and Dr. Sudatta, either of the two. Can the organizers tell me, are these two people there or not there?
So Dr. Sudatta Ray is there. So we have given the access as well, sir.
Okay, Dr. Sudatta? I can't hear Dr. Sudatta. And okay.
Sudatta, you are not responding well. Dr. Amish is. Chat box लिखो किसी जानी पानु ना मैं.
So Ghanshyam, Dr. Sudatta is there?
So he's there, but he's facing problem because his voice is not heard.
Okay, perfect. Fine. So once I hear from Dr. Sudatta, then I'll get back to him. Right, because my first question was to Dr. Sudatta, if he can say hello. So till the time they are there, Niharika ma'am, you are a pathologist here, oncopathologist. Am I right?
Niharika ma'am, you're there.
Unmute, Niharika.
Sorry. Yes, tell me. Sorry.
So
I'm there.
You are oncopathologist, right, ma'am?
Yeah.
Okay, perfect. So, ma'am, let's start with you, because in our panel we have two medical oncologists, two radiation oncologists, one pathologist, and one nuclear medicine person.
Yeah.
Right. So, ma'am,
Yes.
the entire story of any medical oncologist starts with the biopsy.
Yes.
So I just wanted to understand, we are talking today of HER2 positive metastatic breast cancer, and our discussion will be limited only to that. Okay. So whatever questions which I ask, it is in that background that patient has stage 4 breast cancer, HER2 positive. So now, ma'am, in triple positive metastatic breast cancer,
Okay.
in how many do you see triple positive breast cancer versus hormone negative and HER2 positive breast cancer?
How many means percentage wise, if I say?
Percentage wise.
Triple positive will be in 40% and um, only HER2 positive. I think the other is one is triple positive and other is
Hormone receptor negative and HER2 positive.
HER2 positive only. HER2 positive only will be 40% and triple positive will be 60%.
Okay.
If I compare these two.
Understood, ma'am. Ma'am, my main question is that majority of medical oncologists like to do rebiopsy when the patient progresses on the treatment.
Yes.
Do you see the dynamic changes? Because today itself, I have one patient who was HER2 triple positive and patient progressed after 2.5 years. And
Yes.
suddenly HER2 became negative and
Yes.
ER/PR became 8/8, 8/8, which were 4/8 earlier.
Yes.
Do you see these dynamic changes in this setting?
Yes, we see, and we always say that if there is a metastatic disease, we always, or there is recurrence, we always ask for a repeat of hormone analysis, hormone receptor status, and HER2/neu test again, even if it was done in the primary diagnosis. We always ask for a retest.
How common is this, ma'am, in your practice?
It's
Because
not
we believe HER2 positive ones always should be treated as HER2 positive.
But it if not common, but the occurrence has been seen. I have seen personally 6-7 cases in last 3-4 years. 3-4 years to 7 cases in which we got the difference after treatment or difference in metastatic site.
Difference in the heterogeneity of this. Dr. Jogmaya, you are a medical oncologist, ma'am. Can we have Dr. Jogmaya?
Jogmaya, unmute.
I'm there, sir.
Okay, ma'am, if such scenario happens in your practice where HER2 positive earlier becomes HER2 negative in the repeat biopsy, do you treat still with anti-HER2 or you would stop anti-HER2?
I will still treat the patient with a baseline report, like HER2 positive. Because
So then
HER2 positive patients, HER2 positive patients becoming HER2 negative in repeat biopsy actually is rare. Rather,
no,
more
if it
common is
happens, I have a similar case which I see once in 1 year or once in 2 years. If the repeat biopsy becomes HER2 negative, do you take it as HER2 positive or HER2 negative, ma'am?
I will take it as HER2 positive and continue treatment, sir.
Then why do we do repeat biopsy? We should not do repeat biopsy. If we don't want to follow the biopsy report, what's the point of doing repeat biopsy? And every guidelines, they say that in the progression, you should try to repeat biopsy.
Maybe sometimes if the hormone receptor is negative and it becomes positive, then we'll have more option.
But HER2, always once positive, always positive. Is that right, ma'am?
It's actually rare, sir. When it becomes negative, it is little rare. So I have not seen like this.
Saurav, if you get HER2 positive to HER2 negative, I today, just half an hour before, I got one report like that. 3 years of trastuzumab maintenance in a metastatic setting, few nodules on the breast surface. I biopsied those nodules and they turned out to be HER2 negative and mixed ductal and lobular, ER/PR 8/8, 8/8. Would you give anti-HER2 to this patient or you would treat as hormone?
Basically, sir, I have had an experience with such a patient who was hormone negative, HER2 positive to start with. On anti-HER2 therapy, changed to, start with hormone receptor positive, HER2 positive, change to hormone receptor positive, HER2 negative. Now, as per the guidelines, there is no studies as such to show guidelines. We should consider it to be HER2 positive only and continue the therapy. But I actually, seeing the tempo of the disease and all, I had continued only on hormonal therapy and the patient had still done reasonably well.
Right. So this one of the point, nobody has the right answer. We had 1 hour discussion on this point earlier, around 3 months back. And Saurav, you are right that we don't have the data and we have to take the clinical judgment for the patient and decide. So in the sequencing of HER2, I feel one of the important point is you should do a biopsy, and repeat biopsy will tell us a lot of biomarkers for further sequencing. It is not just blind, but Dr. Jogmaya, you are right. Today, the guidelines say that once HER2 positive at the baseline, always treat with anti-HER2. You won't be wrong in that also. Niharika ma'am, the third question for you is Ki67. We are very fond of nowadays ER/PR, HER2 and Ki67. Does Ki67 make any difference in your report?
So it is only we give it as a proliferative index. So we have a cutoff of about 19 to 20% Ki as low, and more than that as high proliferative index.
Okay.
So that's all.
Dr. Jogmaya, going on the Ki67, assuming the report which I told you, after 2 years, the biopsy shows ER/PR strongly positive, HER2 negative, and Ki67 is 4%. Would that change your decision not to treat only with anti-HER2 or add hormone or treat as hormone positive because Ki67 is low?
Sir, in this case, where at the recurrence the hormones have become positive and the Ki67 is 4%, I'll definitely take into account the other features, like after how many years the patient has recurrence and what is the temporal events during the course of the treatment, whether it is a slow growing tumor or not. If the patient disease seems to be a manageable disease, slow growing disease, at this point, I will continue with only hormone.
You will continue only with hormone.
Dr.
Saurabh, you agree? Dr. Saurabh, we don't have any treatment algorithm based on Ki67. Saurabh, I am asking you questions because I still not have heard from Dr. Biswal.
Yeah, sir. Fine. I'm there, sir. I'm there.
Okay. So, Dr. Saurabh, Ki67, high versus low, will that change sequencing in HER2 positive, repeat biopsy in a metastatic setting?
Probably no, sir. Probably no.
We still don't have. And Ghanshyam Dada, what do you do in your practice? Ki67, if it is very low in HER2 positive patients, do you feel that now you should focus more on hormone rather than anti-HER2?
वो बोलते हैं इग्नोर करता हूँ, so lab report wrong है, वो छोड़ दे.
Sir, then we should, sir, Chandrakant here, sir. So then we should
Dr. Chandrakant.
Hi, sir. Good evening. So we should see that whether the HER2 positive is on the DCIS component or the invasive component. It is likely
invasive. It is
no,
invasive.
sir. So when you come across this scenario, you need to cross check whether the HER2 is on the DCIS component, because that is the one that happens here. Low Ki67 HER2 positive, it is on DCIS. It is not an invasive component. That is the key, sir.
Agreed. Chandrakant, so tell me one thing, assuming that we have rechecked HER2, it is invasive component, okay? After 3 years of trastuzumab maintenance, patient has few breast nodules. Biopsy is ER, and PET CT, there is no other progression. Biopsy is ER/PR 8/8, 8/8. Ki67 is 6%, and the histopathology shows mixed ductal stroke lobular carcinoma.
HER2, sir?
Would you, HER2 is negative, 0, not even 1.
So
I can share the report with you, and it is from 2 different labs documented.
So it was a HER2 positive, cured, now has a recurrence, which is ER positive and HER2 negative. Treat as
metastatic upfront to begin with.
Okay, sir.
Patient was having lung liver nodules, lesions.
Okay.
We treated with single anti-HER2 with taxane because patient couldn't afford pertuzumab. For 2.5 years on maintenance trastuzumab, patient is fine and now has breast nodules. Nothing else has come up on the PET scan. Would you give, if the patient can afford generic TDM, would you change to generic TDM or would you add fulvestrant because patient was already on letrozole?
So, I mean, if it is only that side disease, no, sir. So we need to recheck the HER2. So I think we need to re-excise and see the specimen. What is the HER2? And
If
sir,
recheck
if
is
it is
also
HER2,
right, recheck is also negative, Chandrakant, you
sir,
have to
HER2,
answer.
sir, if HER2 is absolutely negative, I will not give HER2 therapy. I will give hormonal therapy. But HER2 is low, then I would give TDXT because in the subset where there is HER2 down regulation post trastuzumab, in that subset TDM1 will not work. I will give TDXT
Correct.
if HER2 is low.
Absolutely. So this is, since we have a mix of panelists, I just wanted to raise these points so that during sequencing of anti-HER2, you need to keep all this in mind because these are the real life scenarios what we face on that. I see Dr. Sudatta Ray. Dr. Ray, can you unmute yourself, please?
So one thing I want to add is the
Yes, ma'am.
difference of can the difference of HOT2 is also possible due to heterogeneity of the tumor.
Yes,
And
can be.
so that's why the HOT2 was negative and later on it becomes positive, or that may be a cause actually.
That
That's
can
why
be
we
a
always
cause.
ask
And
for a
yes,
repeat HER2 after excision of the tumor. Even if you have done the HER2 hormone receptor analysis and HER2 on it through needle core biopsy, again, if it is always good, if you have any suspicion of a response of the treatment, then you can always repeat after the tumor is excised.
Point very well taken, ma'am. Unfortunately, that is what people are advising against it because there is a lot of heterogeneity in the first and second, lot of confusion. That's why people say the first biopsy always is the core biopsy. Point very well taken, ma'am. Over to Dr. Ray. Dr. Ray, you have unmuted yourself. Dr. Ray, tell me, you are from the nuclear medicine, right?
Yes, sir. Yes, sir.
Dr. Ray, every time moment brain metastasis word comes, लोगों के दिमाग में MRI घुसा हुआ है. But my PET CT guy says that, sir, I can identify brain mets on PET CT also. Allow me that. And there's this one paper which I was going through, and this is 2024 January article.
Okay.
And they have said in the methods, if you see that SUV lesions were normalized to contralateral normal white matter and compared with Mann-Whitney U test. I don't understand these things, but can you identify brain metastasis using only FDG PET?
See, we are talking about FDG PET CT. So the
Yes.
sensitivity of identifying brain lesion is solely the credit goes to CT part of the PET CT, because if you just localize the PET avidity in the brain matter where the background uptake is so high, that is not possible. So my diagnostic accuracy is rests with the CT's accuracy in case of a PET CT when you look for brain lesions, not on the PET.
But assuming if you see two brain mets on the FDG PET.
PET CT.
On the PET CT, if you see two brain mets,
yes,
will they disappear on MRI brain? Will it ever happen that you will miss those? It will not. So
No.
any lesion which is, sorry, please go ahead.
In fact, there is underestimation of certain lesions in PET CT, because many times we have seen that if there are 5 lesions in PET CT, if you do an MRI, there will be additional 6 or 7 lesions will be there. Very small lesions will be, MRI will pick it up. Any gross big lesion, PET CT will pick up just due to the CT characteristics, not due to the PET finding.
Not due to the PET finding. Okay, perfect. So this is also one more paper which I came across, and this says that whole body PET CT predicts response to HER2 targeted therapy in metastatic breast cancer. What it says that, this is gallium AB025 scan. Have you heard of that?
Those are quite experimental things, gallium FAPI studies and all those studies. So that concrete data is yet to come. We are not practicing it in in a proper method. These things. So our data is mostly in India is based on FDG base.
Based on FDG. So this EBI is something which is still needs to be seen, which is there.
The data is completely immature. It is coming up.
Okay. Now, my last question to you, Dr. Sudatta, before I come back to you again, based on the SUV activity, can you identify the different histology or the behavior or pattern of the disease?
Yes. to certain extent. Just like in case of breast cancer, a ductal carcinoma generally is more FDG avid, and while a lobular carcinoma is very mild or it has a variable FDG avidity. So in fact, the one beautiful strength of FDG PET in case of breast cancer is the identification of marrow lesions in the bones. But in lobular carcinoma, it is very easy to miss out those marrow lesions because there is hardly any marrow uptake. Even though you can pick up the breast lesions with the help of CT, the uptake is so low in lobular carcinoma that a marrow uptake will be missed on in case of lobular carcinoma. So there is a heterogeneity in there in the FDG avidity in the SUMX parameters.
Okay. Thank you, Dr. Sudatta. That is something which is very, very insightful. Let's come to our radiation oncology colleagues, Dr. Madhuri.
Yeah.
Dr. Madhuri, these are the two things which I have written here: brain mets in HER2 positive metastatic breast cancer and in palliative setting. Can you think of anything else where in HER2 positive breast cancer the radiation has a role?
So the rate of brain only relapse is quite high in HER2 positive disease. I think we've all experienced many of our patients progressing only in the brain. In addition to this, perhaps I would add another thing, oligoprogression. Because we do see in HER2 positive disease, you'll have, because your agents, systemic agents are so good, you'll see patients after 2.5 years on trastuzumab or dual HER2 blockage coming with a single lesion somewhere in the body. So in those cases, it is tempting to give SBRT.
Okay. Dr. Stuti, you agree in oligoprogression disease, we should look at radiotherapy and continuing the same treatment. And then I will ask Dr. Saurabh whether he agrees with that or not.
Yeah, I'll definitely agree with Dr. Madhuri. As she said, brain met, like we see in HER2 positive patients, like brain metastasis is a most common site of recurrence. And like we said that sometimes 2 or 3 metastases, we can add stereotactic radiotherapy to those lesions where we need to improve the cognition. And also
No,
SBRT
I'm not talking of brain mets, Dr. Stuti. I'm talking of oligoprogression somewhere else. A patient is,
oligoprogressive disease as like 3 to 4 metastatic sites we have seen where we can add SBRT to those lesions in bone lesions, and sometimes we have added SBRT to liver lesions as well.
Okay, Dr. Saurabh, you agree in HER2 positive patients, suppose assuming patient can afford TDXT, would you give SBRT to oligomet up to 3 lesions, or would you change to TDXT?
So basically, sir, my main tendency here would be I would be more inclined to change the systemic therapy, but then the oligo progression is something where if we go for local therapy. So for example, I can say we had a patient who actually had a progression only as a very small lesion in the lung. Nowhere else, everywhere disease control, trastuzumab, pertuzumab was continuing and she was doing very well. Only a small site at the lung. Now that part, whether to go ahead and just change a very, very important systemic therapy, by that time TDXD was not available. So we actually went ahead, SBRT was considered, not done. Surgery had to be done for that lesion, and we had actually continued trastuzumab, pertuzumab. So that is still a possibility. But if there are, so that's what.
Right. Okay. Understood. So I think something which everybody would agree that oligoprogression in a slow biological behavior of the patient, we can consider SBRT. Dr. Madhuri and Dr. Stuti, I completely agree with both of you. We have now 7 to 8 minutes, 7 minutes more left with me. So Dr. Jogmaya, please tell me that you agree with this NCCN version of first line, second line, third line, and fourth line sequencing, which is the main topic today of HER2 positive stage 4 metastatic breast cancer.
Yes, sir, definitely. Because for patients who actually progress HER2 positive metastatic breast cancer patients, ideally the dual HER2 blockade should be tried, and trastuzumab with the availability of trastuzumab deruxtecan now for patients who are affordable, definitely that is also a very good choice of drug. And also TDM1, which has been available. So we have these good drugs in our armamentarium. So definitely this will be the treatment sequence which I will follow.
You would follow. Dr. M.V. Chandrakant, can you come up, please, your video? There's a very important question to you. MV है कि चला गया?
सर कैसे जाऊं सर आपके सामने हो क्या?
MV,
हाँ सर.
first line, we all agree Cleopatra trials, 7.5, 8 years of follow-up, dual anti-HER2 with docetaxel. Second line is TDXT, third line is TDM1 or HER2 climb. Fourth line is, you agree with this sequence what NCCN guidelines have given?
I agree, sir.
You agree. Okay, perfect. Now, question is to you is after TDXT, will TDM work? Do you have any data of that? Okay. Now, just Dr. Chandrakant, just rewind and imagine that lung NCCN guidelines, and we have ALK positive or EGFR positive. They still have Jeftinib as category 1 and Crizotinib as category 1 in the first line in some circumstances. Why here the TDM1 is pushed to the third line and why it can't be one more choice in the second line?
Sir, there is a head-to-head comparison of TDM1 versus TDXT. TDXT is superior. So I think the TDXT should be in the second.
Lorlatinib versus Crizotinib head-to-head comparison hai.
Yeah.
Osimertinib versus first line head-to-head comparison hai. But they are still category 1 in the first line. They are not dropped down to second and third line.
So the magnitude of
My
difference
point is, Chandrakant, in country like India, okay, if we don't have TDXT available and on top of that 10 to 12% of lung toxicity, the moment we write here TDM1 as the third line, the person gets confused. And do we have the data where it will work in the third line after TDXT?
No, we don't have some. I agree with you. So we should have had another option in the second line.
Correct.
In the scenarios where TDXT is not accessible. I agree with you.
Right,
But Amesh, so
yes, Dada.
the lung cancer scenario is different. So we are talking about anti-ALK or anti-EGFR as a first generation, second generation, third generation. So there is no second line or third line. So we are talking about a first line setting. But in breast cancer, we are talking about a first line, second line, and third line. So because that scenario doesn't come in lung.
No, Ghanshyam, Jeftinib plus chemotherapy you give to the patient.
First line, that is the first line.
First line. Patient progresses, 1 minute, patient progresses, T790M still positive, you give osimertinib. That is the second line. Is that correct?
Right.
But today, if I have a choice, I can select between Jeftinib versus osimertinib as the first line also.
So yeah, we are arguing for the first line only.
So that's what I'm saying.
Anti-ALK also, we are arguing for the first line only.
So here what I'm talking of in a second line setting, dropping TDM1 to the third line, when TDM1 in 2012, Emilia head-to-head trial had shown that in the second line, it is better than Lapatinib capecitabine.
Because at that time, TDXD was not there. So now the CNS activity is much superior.
Agreed.
That's why it has gone up.
Agreed.
So no, sir is making a different point. He's saying that we should also have TDM1.
Yeah, you have such an important molecule. Now, since TDXD has come, should we put it in the dustbin? That's what he's asking.
That is
we
what I'm
do
saying.
That. We should have it as a second option also. Yes.
3 more minutes, Ghanshyam. Since I have seen you on the video, tell me, why has TDM1 underperformed in Destiny 03? This is the chart which I have. If you open the Emilia chart, I couldn't download that. There, the median PFS of TDM1 is 10 months. And here, in TDM1, the median PFS is 6.8 months.
Maybe because of the CNS disease. So that the whole difference will be a CNS disease. And also the toxicity, because you've seen trastuzumab emtansine means TDM1 is more toxic. So there were more dropouts because of thrombocytopenia and for the high SGOT SGPT. So
Dr. Chandrakant, any other thought? Okay, since we don't have time, I'll share because I have read about it. Not that initially I thought. In Destiny 03, the dual anti-HER2 patients were higher. So what they found out, what they hypothesized, that probably the downregulation of HER2 mRNA was higher in Destiny 03, and that's why the HER2 resistance TDM1 worked less better, and TDXT was able to overcome that. And that can be one of the reason. But if you see here, we still don't have median OS in either of the arms in Destiny 03. So picture abhi baki hai. I personally think TDM1 should not be put in the dustbin. This is the response rate. We still have the OS data immature. Okay. Now, Saurav, I think this can be last 1 to 2 minutes. That's all. And I'll close my panel myself before organizers tell me anything.
Oh, no, please carry on, please.
So, Saurav, patient has taken TCHP, responded well. Sorry, C hata do. THP responded well. Progression after 3 years. MRI brain shows 3 metastasis. There is no scissors but blurring of vision. TDXT or tucatinib?
I would go for usually TDXD, sir, if it is there. So nothing like TDXD as of now. The CNS penetration is too good for TDXD, and also we are seeing that even if we have received here for 3 years THP, means trastuzumab, pertuzumab has still worked, but still it has thrown up metastasis. Now TDXD has a very good extracranial control also. And we have the data now for THP after progression on first line TDXD. So considering all these things,
I agree. NCCN guidelines Saurav says that if the patient has brain mets, tucatinib, which was approved in the 3rd line, can move up to 2nd line. Chandrakant, what would you give, TDXD or tucatinib? So in favor of Saurav, I must say that if you see the stable brain metastasis, no also and yes also in TDXD, if you see the hazard ratio of 0.27 and 0.38, and the same hazard ratio in tucatinib, if you see it was 0.38. So there was no difference. Which one to choose, TDXD or tucatinib?
So tucatinib with CAPE, no? CAPE, tucatinib.
Capecitabine, trastuzumab and tucatinib. HER2 client.
TDXD.
क्योंकि अभी we are used to TDXD and available है इसके लिए.
Nice, sir. I mean, if you look into
data.
Sir, my point is, if a patient has received Cleopatra first line, the patient must receive TDXD second line. If a patient has not received PER2 in the first line, then I am okay to use something other than TDXD.
Other than TDXD, even though we are not debating, and I completely agree with you, Chandrakant. If we would have been debating, I would have said something else. Chandrakant has made a extremely important point in the sequencing. Please see first line. Have you given dual HER2? If you have given dual anti-HER2, the HER2 mRNA expression goes down drastically and you need a stronger drug. You don't need a weaker drug, and that's why probably TDM1 has gone down. So my point is, status keeps changing in HER2 very fast every day. Radiation oncologists help us, nuclear medicine help us, pathologists help us, and we keep discussing like this, the way you all have, set up the agenda of this. We have to keep discussing to understand what is better sequencing of that. With that, I close my panel. Thank you so much for giving me this opportunity, and my sincere apologies for being 2 minutes late.
Thank you so much, sir. It was a wonderful discussion and a lot of insights from everybody. The TDM thing is still to be closed in future, probably.
Right.
Thank you so much, sir. Thank you so much, all the panelists. Thank you so much, Amish, sir.
We'll
move ahead to the next talk for the day.
Thank you so much.
Our next talk is by Dr. Kanucharan Patra on managing brain metastasis in breast cancer. He's a radiation oncologist from Visakhapatnam. So I would request you to please kindly try to manage the time.
Okay.
Thank you so much, sir. Over to you, sir.
How long I can talk?
Sir, you have 15 minutes.
15 minutes. Okay. 15 minutes is much more time. Okay. Can I go ahead?
Sure, sir. Sure. Thank you so much.
So, brain metastasis in a breast cancer is almost similar to other malignancies, and except some few points. Where should we go for surgery? Where go for the radiation? Where go for the stereotactic radiotherapy? Where we go for the whole brain RT? So, if you see, there is a word called observation also. In brain metastasis, observation also a point, and surgical indications, radiation indications where we can go whole brain RT, SRS, single fraction, multifraction, and post-op RT. So there is various guidelines from ASCO, SNO, Astro guideline. There is a ISMO guideline also. I have covered all these guidelines. So we have a 3 protocols, SRS, meaning there is a small radiation, focused radiation, whole brain radiotherapy with hippocampal evidence. So whether brain's MRI screening newly diagnosed cancers, we should do breast cancers. Yes. So apart from the NSCLC and stage 4 melanoma, we should go for a HER2 positive and triple negative breast cancer. We should have a screen for the MRI whenever there is a newly diagnosed breast cancer. So one thing I want to highlight here, when there is a patient with double contrast, when we are sending for the MRI to the patient radiologist, we ask to go the double dose of the contrast. If you give the double dose, the number of more prominent lesion, and apart from that, the lesion size increases with double dose. And apart from that, number of lesions, you can see there is a single dose, there is no only single lesion. But after the triple dose, even you can see there are 2 lesions brightly enhancing comparing to the single dose of the contrast. And if you take a delayed contrast, you can see 2 lesions are delayed contrast also happening. So when you are sending a patient for the brain metastasis, because you can, as you know, HER2 positive breast metastatic lesions, they have a miliaria mets. So multiple lesions you can see. So always going for a SRS things, you just ask the patient, ask the radiologist to take a delayed scan. Apart from that delayed scan, you can ask for the triple dose and double dose of the contrast. As you know, more than 1 Tesla, 1.5 Tesla, and 3 Tesla, definitely 3 Tesla looks brighter and easier compared to the 1.5 Tesla. You can see delayed contrast also very important. You can see there is no lesion at the, if you give contrast. After 10 minutes, there is a small lesion, but after 15 minutes, there is a big, small lesion is more prominent. So, delayed contrast, 3 Tesla, and double dose, triple dose contrast is needed when you are taking an MRI for the brain metastasis. Another thing is the galbut. We are usually gadolinium you use, but if you other contrast like galbutoral, and if you use, there is the lesions become more prominent, and that is also helpful to for the diagnosis of hidden metastasis. So where we can go for a whole brain RT. So when there is a multiple brain mets, and when there is a multiple brain nets, and there is a like HER2 positive breast cancers where you see the miliaria mets, we should go for the whole brain RT. But supportive care also is in there one thing when we can omission of whole brain RT when there is a patient with poor performance starts less than 50, kps less than 50 or 70. So sometimes there is a called hippocampal evidence. So hippocampal evidence, we are avoiding the hippocampus during whole brain RT, whether in a role. So if there you are expecting more than 4 months of the expected patient, so better to give memantine during the radiation and to spare the hippocampus, slightly tricky technique, radiation technique. You can ask your radiation oncologist, please spare the hippocampus for the better memory. When should plan SRS alone? When there is a 1 to 4 metastasis, you can go for the SRS. But even if in 5 to 10 cumulative tumor volume is less than 10 ml, you can go for SRS. So if if planning SRS is more the 12 gray volume, you just look after. If there is a more than 10 cc, better we go for the fractionated SRS. So can you give some radiation sensitizing agents with Helven RT? Better not to give any radiation sensitizing agent. So SRS dose schedules is a small lesions as per the radiation oncologist. A small lesion you can go for 20 to 24 gray. More than 2 centimeter, less than 3 centimeter, you can 18 gray. SRS you go for the 15 gray if there is a more than 3 centimeter lesion. If there is a performance strategy less than 50 and less than 50, we can observe. And if performance strategy less than 70 and no system of therapy, you can consider whole brain RT. We can avoid radiation in symptomatic brain mets, asymptomatic brain mets. So sometimes most of this, because of the advancement of the MRI and PET CT, a patient is asymptomatic. Can you withhold the radiation for the meantime. Yes, if you are using a targeted agent, what is good penetration CSF, you can avoid giving radiation to the brain if there is a patient is asymptomatic. Then what is the targeting agents? If you see the breast, there is a HER2 positive, ERPH, these molecular markers. If you see the combination of tucatinib, trastuzumab, and capecitabine may be offered in HER2 positive metastatic breast cancer who have a asymptomatic brain metastasis progressed on the trastuzumab, pertuzumab, or combination. If these are agents are used, patient is asymptomatic, you can delay the procedure till patient is symptomatic. So should a asymptomatic brain patient receive radiation? Yes, any breast cancer patient who is symptomatic, they should receive radiation. What are the candidates for surgical resection? Sometimes we are fumbling whether to send for the surgery or not. Yes, so there are very few things. Suppose this is a lesion where compressing the brain stem, definitely you need a surgery. If there is a mass effect, you can see the lesion is compressing opposite brain, patient will have poor performance status. Don't ignore. After giving surgery, you take the surgery out, tumor, patient will have a performance level increase. Large cystic lesion, usually they don't respond to the radiation easily. So cystic lesions better go for the surgery first. And as you know, unknown primaries, you can go for the radiation surgery first. So what type of radiation should be patient should be avoided when undergo resection? You can plan for SRS. So SRS, these are the radiation dose volumes. I'm not going to detail. So SRS dose volumes if you have cavity SRS. So there is a good thing you have to understand when you have patient undergone a surgery for the radio SRS for the single brain metastasis. The radiation is not so straightforward as like other part of the whole brain without surgery. So if patient undergone a surgery for the brain metastasis, you have to treat the surgical tract, dura, flap, cavity, dural sinus, enhancing. So you have to complete all the things you have to treat. Otherwise, there is a called sugar cheese pattern of metastasis. It will happen. So when the patient undergone a surgery, you have to do the cavity radiosurgery. So usually when the patient undergone a surgery, we should wait for 3 weeks to 4 weeks to go for the radiosurgery. If the patient are asymptomatic, there is a high performance standard is poor, you can start Dexa, ranitidine, Eptoin, SOS, antiemetic, and mannitol as per the requirement. So use of steroids and anticonvulsants should be there needed. Steroids should only be used if patient is symptomatic. Anticonvulsants used unless there is no epilepsy and no seizures. But in my practice, I give the anticonvulsant during my treatment, even patient is asymptomatic, because small lesions, if there is a epileptic focus will be there, patient will create the patient's GC may come down. Because now the drugs are like Brevipil, Levipil, these are very good drugs where the minimal side effects. Yeah, remember one thing, when you are going for a whole brain RT or radiation therapy during the brain metastasis, you should avoid Eptoin. Phenytoin is no longer used because it causes Steven-Johnson-like syndrome. Levetiracetam is a very noble drug. When you want to use anticonvulsant, use the levetiracetam or brevaracetam for the seizure control. When should I do any imaging after the treatment? Yes, I can use every 2 to 3 months or when patient becomes symptomatic. When you are asking, when a confusion, when there is a because of necrosis or some reoccurrence, you should compare with the MRS and perfusion scans. So in a brain metastasis within breast cancer, these are the deciding factors like histology, number of lesions, GTB volume, prior whole brain RT, performance status, availability of expertise, patient compliance. So these are the factors it is used to determine the role of radiation in the brain mets in breast cancer. If patient is asymptomatic, you have a good penetration of your targeted agents, don't go for the radiation. If patient is symptomatic, definitely go for radiation. Good performance status, go for radiation. Poor performance status, see the surgical surgery possible to surgical decompression, or poor performance status due to you can use some the mannitol Dexa for few days, see the improve the performance status. If oligometastasis like 1 to 4, you go for SRS. Polymetastasis, you go for the whole brain RT. Systemic burden, if there is oligotype, so systematic burden, then you have to think of whether targeted agents is possible or not. If there is no targeted agents, go for the radiation. Miliaria mets like HER2 positive breast cancers, you have to go for a whole binary. So primary outcome is a poor, and again it is depends. So if there is single metastasis, definitely go for SRS. If there is multiple mets, you can have to weigh between the benefits and risks of the radiation and outcome. Socioeconomic status, patient, if you go for the whole vein RT, patient can afford, but if there is no targeted agents, but SRS may not be sometimes possible in the low socioeconomic status. Patient compliance, SRS is better. Expertise and availability, if, availability of the equipment and expertise, go for the SRS if 1 to 4 lesions, otherwise go for the whole vein RT with hippocampal evidence or whole vein RT. Priority, whole vein RT, SRS always to be considered when you are giving re-radiation, and volume of the dose, volume of the tumors should be less than 15 cc when you are going for the radiation SRS. More than 15 cc you go for the whole vein RT. So and so if you go for the Pittsburgh algorithm for the brain metastasis guideline, if symptomatic and mass effect, do resection, then do SRS. If patient having less than 25 mm, 25 cc, you go for SRS. If more than 25 cc, go for the multifraction SRS. If many lesions, leptomeningeal spread, or there is a miliaria mets, go for the whole brain RT. Thank you very much. This is all about my presentation in the breast cancer with brain metastasis.
Thank you so much, sir.
Garima, can I
It was a
ask
wonderful
a
session, sir.
question? Kanubhai, we have some time, if it is okay. Kanubhai, are you there?
Yeah. Please.
Yeah. So this is Saurabh here.
Yeah. Please tell me, sir.
So just I wanted to know, is there some data to say that when you go for radiotherapy to the brain, then there is increased toxicity in the brain with the use of TDM1? If it is being given, is there any data to say like that, or there is some increased necrosis or some edema due to TDM1 if you give it with RT to the brain?
Actually, honestly, I have not gone through any article by TDM1. I have to see again. So,
Okay.
but I have no idea about TDM1 and again toxicity increases or not.
Okay, fine. Thank you.
If TDM1 is there, if there is a good penetrating agent, if you are thinking if patient is asymptomatic, you can wait for that.
Okay, fine.
Thank you so much, sir. Very wonderful session. Any other queries? We have 30 seconds, or we can move ahead to the next. Kanu sir, everybody is telling so multiple number of thanks to you.
I have a question to Dr. Kanu.
Yes, sir.
Dr. Kanu, I am your fan. So you tell me, how are you consistently maintaining this academic for last I think 3-4 years continuously? I mean,
8
what
years.
is the secret? 30 seconds for you.
That he won't share on the public platform. You have to go and meet him personally, you know.
Just
No, this is the highest number of audience listening. That's why I'm asking.
Yeah. No, just actually it is a fun, and I want to learn. Just I want to update myself, how to keep updating. I just praying God. So one day I thought, why not make a slides what I learned today. Tomorrow that will be, and share the knowledge to everybody when the people are not accessible, and I made it a hobby. And I think I'm going to complete 100th volume by July 2024.
So Kanu bhai, I got my DM entrance answers right after looking into your slides. So I am today what I am is because of your slides. Thanks again.
Somebody met me in the Tata. He told, sir, because of you,
It was me.
Yeah. Thank you very much for this session.
Thank you so much, sir. Thank you so much, everybody. We'll move ahead to the next sessions for the day. The next talk is by Dr. M.V. Chandrakant on evolving trends in management of HER2 positive metastatic breast cancers.
Yeah.
So I would request you to manage the time, sir.
Yeah, absolutely. So I would thank Ghanshyam sir, for able to accept and change the schedule. But I think it is relevant because I am speaking HER2 after Dr. Amish. So again, I would thank Ghanshyam sir again for this opportunity. And so I will just take you through the TDXT data, the recent advances in HER2 positive breast cancer, and I will take you through how a medical oncologist thinks when you look into HER2 positive disease. So this is a sequence which I will be discussing through, and let's see. So I am speaking of a molecule called TDXT. In oncology, there are out of 100 molecules, you will get 2 or 3 molecules that are really efficacious, that makes difference to lives. And this is one such molecule where this has revolutionized the way we treat a HER2 positive disease. I've changed my mind of how to treat lung cancer is because of immunotherapy, because of drugs like lorlatinib, osimertinib. So like that, the moment I come to HER2 positive, any cancer for that matter, I am confident, the moment patient sits in front of me, I'm confident I can treat him well because of one drug, and that is TDXT. So which has changed the landscape of how to treat HER2 positive breast cancer. So let's see what HER2 positive breast cancer is. 30% of all breast cancer patients become metastatic, and 20% of them are HER2 positive disease. So we all have seen the problem. Trastuzumab gone, TDM1 gone, lapatinib gone, and what next? We were all in that gray area and HER2 low, what to do? So this is what we had. Now we have something called a magic bullet, that is TDXT, and I will show you the data, which is extremely impressive. So HER2 is a bad thing. HER2 is bad because we didn't have a good drug to treat it. The moment HER2 is positive, these cancers are fastly multiplying. They have a high Ki67, and then they have a higher tendency to metastasis. They get into brain, so it's an aggressive disease. Whereas a hormone positive is an indolent disease, slowly multiplying. So HER2 positive is rapid, fast, and furious. So you need to treat it properly with a proper targeted therapy. Okay. So what are the unmet needs in HER2 positive disease? If a patient has a HER2 positive breast cancer, metastatic, the chances of him going to second line therapy is just 75%. In our setting, it is less than that because the patient will die before going on to the second line treatment. Brain metastasis, visceral crisis. The patient dies before going to second line. Therefore, the need for giving the best treatment as early as possible. In oncology, if a disease is mortal, if you have a good drug, don't keep in your pocket. Give it as early as possible because your patient may not live for the best drug in the next line. So you can see the number of dropout rates at every line of treatment. And 22% patient drop out before second line. This is in Western data, where in the clinical trial control data. But what about Indian data? What about our setting? Majority of them drop out. So that's the challenge. So first line therapy in the present day, the standard of care is Cleopatra. Cleopatra is dual HER2 blockade of taxane, pertuzumab, trastuzumab, and phenomenal improvement in PFS and overall survival. We never saw, like 6 years of, 5 years of overall survival median. That was phenomenal for the first time we saw in Cleopatra. Even today, this holds the standard of care. And then we had TDM1. It did make difference, but it was like an unmet, and it made little bit difference. We have very few patients going on for TDM1 for a long time, but it did make a difference in Amelia. TDM1 versus KPLAP was the comparison. And then this is very important, what I was trying to make. If you have given pertuzumab in the first line, and then what happens is if I give dual HER2 blockade in the first line, these HER2 positive cells undergo a down regulation in nearly 40 to 50% of patients. And then giving TDM1 may not be that helpful. Just look into the dip in the way TDM1 works if I have used PER2 TRAS2 in the first line. So giving dual HER2 blockade in the first line, that means TDM1 is less likely to work in the second line. These are some more data saying the same thing. So first line, if I given dual HER2, then the next line, if I give TDM1, it may not work that well. That is what you need to remember. If I have not given pertuzumab, trastuzumab, dual in the first line, then I may use TDM1 in the second line. But if I've used dual in the first line, then be careful before using TDM1. You need to see is there a HER2 receptor downregulation? And this is data in front of you. A significant number of patients exposed to dual HER2 in the first line undergo HER2 receptor downregulation. So what is the difference between TDM1 and TDXT? For TDM1 to work, the cell has to be driven by HER2. It has to be HER2 driven. Whereas for TDXT, the cell need not be HER2 driven, but just a positivity of HER2 is sufficient. I will tell you why. So these are in the HER2 positive subgroup, we are very fortunate to have so many new drugs. TDXT is the star in that. We have margetuximab, not that efficacious. Tucatinib, good. Neratinib, pyrotinib, these are the drugs that have come actually. So let's see what TDXT is all about. So you have this blue color one, that is the antibody trastuzumab. Along with that, there are cleavable linkers. Just read this word again and again. Cleavable linker. And then read this one. 8:1 is the drug to antibody ratio. That means HER2 is just there to just take, it's a vehicle to take the drug to the target. Okay. And the moment it is there in the target, it will release something called deruxtecan. That's a topoisomerase inhibitor. So just look into the mechanism of action. HER2, so the cell need not be a HER2 driven. Just a HER2 positivity is sufficient. It blocks, and then the HER2 antibody will take the chemotherapy moiety deruxtecan with the cleavable linker. It gets inside, internalized, and then it gets cleaved. It's very important for the linker to be cleaved, and then after it is getting cleaved, the topoisomerase 1 inhibitor, which is deruxtecan, gets into the cell, and then it releases. Topoisomerase harms the cell, not only the cancer cell, but also not a HER2, but also the bystander cells. Therefore, even a mild HER2 positive, 1+ is sufficient for this drug to act. So HER2 low is a big subset where TDXT acts well. So very important is the cleavable linker, and the antibody to the drug ratio is 8:1. Please remember these. So this is the comparison of the molecule, two drugs, TDXT, TDM1. TDM1 phenomenal. It did really revolutionized treatment before TDXT. Now in the era of TDXT, look at that. 8:1, 3.5:1. And then cleavable linker present with TDXT, whereas it is absent in TDM1. Bystander effect is yes and no. Therefore, for TDM1 to act, the cell has to be HER2 3+ or FISH positive, whereas for TDXT to act, even a low HER2 positive is sufficient. Okay, now I will discuss for Destiny 01, Destiny Breast 01, 02, 03, 04. What is 01? 01 is a single arm study of TDXT in heavily pretreated HER2 positive breast cancer patients, showing that TDXT works even if they're treated multiple times. What is Destiny 02? Destiny 02 is head-to-head comparison of TDXT versus treatment of physician choice. And Destiny 03 is second line, or TDXT, TDM1 head-to-head comparison. Destiny 04 is HER2 low subset. So let me go through 01. Heavily pre-treated HER2 positive disease. What have they received before? Everything. TDM1, trastuzumab, pertuzumab, everything received. And the best response to TDM1 was, just 42% disease stability, and 35% had disease progression on TDM1. And look at the response. Hardly you get such a response in a heavily pretreated disease. Wonderful response. And this speaks of the drug. 62% overall response rate. Duration of response 18.2 months. And irrespective of the prior pertuzumab hormone status, it works. It works, and it works really well. 1.5 years of duration of response in a heavily pretreated disease is phenomenal. And the overall survival in those patients who are about to die in 3 months are living so long, like more than 2 years. And that's how the drug works. So this is the head-to-head. This is CNS, it works in brain also. The CNS response rate is only 60% response rate. That is again phenomenal. So the problem if I reserve TDXT for later line setting is interstitial lung disease chances are higher if I'm giving in a patient who is having a poor GC and heavily pretreated patient. So the better, the earlier I give, the more efficacious TDXT is, the less lung toxicity it has. Therefore, use the drug early and do not reserve for later lines. So you can see on 13.6% any grade toxicity, is there. So that is the point with lung toxicity with TDXT. But you need to have a low threshold, keep doing HRCT and see if the patient is symptomatic. Okay, then coming on to the Destiny B03. I think today the most important trial that you all have to see is this trial, Destiny B03. What does this say? This is pre-treated patients who have progressed on TRAS2 or TRAS2 plus TRAS2 and head-to-head comparison of TDXT versus TDM1. Good number of patients, 261, 263 patients. Primary endpoint, PFS, and secondary endpoint is overall survival, response rates. Brain mets were allowed. And Asians were majority. Brain mets, 1/4 of them had brain metastasis. Visceral mets, 70% of them. Uh, about the patient disposition among the two subgroups, and just see 99% of them had trastuzumab, and 62% of them had pertuzumab. So a significant number had dual HER2 blockade in the first line. And you can look into the number of lines, one line in 41, two lines in 23%, and three lines in 16% patients, and even more than 5 in 12.6% patients. And this is the head-to-head comparison of the progression-free survival of TDXT versus TDM1. Hardly you will see such curves in oncology. And this is the hazard ratio of 0.28, which is phenomenal. You can see the plateauing of the curve. That is how this curve. And look at the forest plot. Everything towards the left. Hazard ratio is 0.2, 0.3, irrespective of previous HER2 treatment, visceral disease, previous lines of therapy, brain metastasis, brain mets at baseline, all the subset TDXT works. So in a patient who has progressed post trastuzumab, then the second line must be TDXT based on this data. Then looking on to overall survival, hazard ratio is 0.43. So this is the difference p-value is 0.037. And then again, overall survival, all subgroups have benefited. And brain mets at baseline, if it is there, the benefit is much huge. The hazard ratio is 0.3 if there are no brain mets and 0.25 if there are brain metastasis. And this is the response. You get the waterfall plot of response rate of TDXT and TDM1. Everything down, down, down with TDXT, whereas very small part going down with TDM1. So nearly 78 versus 35, more than double the amount of response you get. The clinical benefit rate is also double. The duration of response is significantly longer with TDXT. So around 17% of patients in TDM1 went on to take TDXT the subsequent line. That means you lose out patients if I am not giving TDXT in second line. These patients may not live long to get TD in the subsequent line. TDM1 doesn't have that good brain penetration. Okay, so this is the toxicities, and this is the most common adverse events. Just be cautious about the cytopenias, and very important is interstitial lung disease. So around 15% patients are the ones that you would get some interstitial lung disease. You need to have HRCT chest to find it out. Quality of life is better with TDXT. And this is the first phase 3 randomized trial, TDXT TDM1 head-to-head comparison. PFS better, and it is consistent across all the subgroups. And there's a trend for OS benefit also. Okay, so the take-home message is post-trastuzumab, TDXT is the way to go if a patient can afford. So tucatinib, again, I'll just take you to this trial is flawed because the comparator is weakened because lapatinib should have been then in the phase of placebo. However, with these nuances, tucatinib did show a good CNS activity. The difference is there, but not that like TDXT. To climb done, and then you have neratinib, fair enough, not a great drug, but has shown some efficacy head-to-head with lapatinib. These are some mild differences. So what is the current algorithm in the present day? First line, Cleopatra. Second line, Emilia gone. Destiny B03. TDXD is the way to go. And third line, you will reserve tucatinib trastuzumab or other options. So second line option, TDXD, is better than TDM1. The trial name is Destiny B03. This is what Dr. Amish was saying. The Cleopatra first line, second line, no Emilia. Destiny B03. And third line, we will play with other drugs like tucatinib. So, conclusions. So, first line THP and second line TDM1 treatment, the PFS drops numerically significantly. Like if I given dual HER2 in the first line, TDM1 will not work that well. And then based on Destiny B03, you have head-to-head comparison of TDM1, TDXT is better. The other drugs like margetuximab, tucatinib have not shown that benefit. So with this, I would thank the organizers for the opportunity and thank all of you for your patient listening.
Thank you so much, sir. It was a wonderful talk. Brilliant take-home
Excellent,
message.
Chandrakant. Beautiful talk.
Beautiful, beautiful.
Thanks, Saurabh.
We'll quickly move ahead to the next. We are running short of time, so we'll quickly move ahead. The next topic for today is the debate. The debate for the next topic is neoadjuvant carboplatin and triple-negative breast cancer. It is the standard of care. For it, we'll be talking Dr. Vivek Agarwal from Kolkata. Against will be Dr. Joydeep Ghosh from Kolkata. An expert opinion is by Naresh Somani sir from Jaipur. We have Naresh sir here.
Yeah.
Joydeep sir. Over to you, Naresh sir.
Good evening and thanks to Ghanshyam and his team. One word of caution to Ghanshyam for the next meeting. Please do not pitch up two speakers from the same city for and against. That's not good for health of your meeting and for them also. So anyway, so we all understand that in the triple negative, especially when we want to give them the new adjuvant treatment, the multiple options come in the mind. Like we may think of giving the immunotherapy based treatment. We may think of giving them the carboplatin based treatment. We may think of escalating the treatment based on the pathological response in the adjuvant setting like capecitabine. And if the patient is the BRCA positive, then maybe that in the adjuvant setting. So the things are being crowded and complicated, and probably these all treatments are driven that what we have given in the new adjuvant setting, and based on that we try to give them the adjuvant treatment. So to see what is the role of the carboplatin or the platinum for that matter, and what are the surrogate or the direct markers for that, let's have the first Dr. Vivek Agarwala, that how he wants to put in favor of the carboplatin, which is easily available and the cheaper drug. Dr. Vivek, over to you.
A very good evening to all of you. Thank you, Naresh Somani sir, for a very kind introduction, and thank you, the organizers, especially Dr. Ghanshyam Bishwa sir, for giving me this opportunity. So, my topic is to talk about the role of neoadjuvant carboplatin in triple negative breast cancer and whether it is a standard of care or not. So just let me share the slides. If you will give me just
can the back office help you if you are not able to share, because all your time
just,
which is going.
give me 1 minute. I'll just enter the.
And there is a one question in the chat box for Dr.
Yeah, I think now the slides are visible.
Yeah. Go ahead.
Yeah, yeah. So let us start, this topic with some known facts which are established beyond debate. So neoadjuvant systemic therapy is now a standard of care for all triple negative breast cancers which are more than 1 centimeter in size. When we take about early triple negative breast cancers eligible for neoadjuvant, we talk about low risk kind of a disease which is T1CN0, or a high risk which is T greater than or equal to 2 centimeters or node positive. And both of them are eligible for neoadjuvant systemic therapy as per the standard guidelines. The high risk cases are the ones which actually are more relevant and we get in our country. But when you talk about global guidelines, even the low risk ones are eligible for neoadjuvant treatment. Now, why is neoadjuvant a standard of care for TNBC? because this gives us a biomarker called pathological CR. This is the main reason. There are other reasons, but PathCR is both a prognostic and a predictive marker. Prognostic because it strongly correlates with DFS, EFS as well as OS, and this correlation has found to be strongest for triple negative breast cancer and less strong for HER2 positive and ER. And why predictive? Because it predicts benefit from further adjuvant treatment with capecitabine or olaparib. Now, these are some known facts, and we will not debate about all these. And I think my fellow debater will agree with them also. With this, I state this motion that adding carboplatin to a standard anthracycline taxane is the new standard of care now. It is already an old standard for many of the institutes which have already adopted this practice. And why do I say so? Because most of the guidelines endorse this as standard of care. Because I'll prove you that it improves PathCR, it improves EFS, DFS as well as overall survival also. It has an acceptable safety and tolerance. And just as Dr. Somani said at last, it is very much cheap and accessible. So it has all the things why it should be called a standard of care. Now, some of the arguments which probably will be rising in this debate, which my fellow speaker, which my fellow debater will, which I will refute in the coming slides, is that he will tell us that OS benefit is not consistent across all trials. But I again say that OS benefit is there, and I will prove it to you. He will tell us that DFS and OS benefit is only in some young patients or patients with heavy disease burden. But I'll tell you that no, this was only seen in one trial and not the all trials. There were multiple trials done. Also, he might tell that DFS benefit is not seen if dose dense regimen is used. But no, DFS benefit is seen whether you use dose dense or not. Yes, it may be less or more. He will tell that it increases toxicity, but I'll show you that the toxicity profile is acceptable. And he will tell us that Keynote 522 data included carboplatin in the regimen. It's a standard of care, but not all can afford IO. But here the debate is not about affordability, it is about standard of care. Now let us see this NCCN 2024 guidelines, and category 1 recommendation for high risk TNBC is the Keynote 522 regimen, which includes carboplatin. Also, if you talk about patients where anthracyclines cannot be given, it states that category 2A combination is Pacli carbo or dosi carbo. So carbo is there in NCCN 2024. It is the standard of care. And let us first look at the ESMO 2024 guidelines, and you can see whether we talk about low risk patients or about the high risk patients. Category 1A recommendation is 6 to 8 cycles of chemo, including taxane, carboplatin. And in the high risk with pembrolizumab, it is even a category 1A recommendation with an MCBS score of A, which is the highest recommendation. So after these two slides, I don't think there is any need for further debate to say that whether it is the standard of care or not, because the guidelines state. But then let us further elaborate to see whether it improves PathCR. So again, PathCR is the most significant endpoint in this context. Because it's the primary endpoint in the older studies. And across all the studies that you see, there is a significant improvement of PathCR by 15 to 20%. Maximum PathCR benefit was seen in the brightness study, and it was seen, it is irrespective of the BRCA status. So gone are the days where you will only use in the BRCA positive patients. The JEPAR 6-2 study as well as the brightness study showed that this improvement is irrespective of BRCA. And we talk about our own patients, our Indian patients, the Tata study showed that the PathCR was improved by around 15%, 55.2 versus 41.5, which are the significant improvement as per the statistical value. Now, these are the improvements in PathCR. JEPAR 6, almost 15% improvement. CalGB, around 14% improvement. Brightness, almost a 27% improvement in PathCR. So what is the PathCR when you don't use platinum? Close to 30%. When you use platinum, it goes to around 50%, and when you use pembrolizumab, it goes even up to 65%. This is what is the data. This is the again the forest plot analysis which looked at the meta-analysis which was done in 2018 by Poggio, and this meta-analysis also shows a significant improvement in PAT-CR which is favoring the use of platinum. Another AIMS meta-analysis, the recent one published in 2022, again it shows a clear-cut improvement in PAT-CR in all the conclusion of the meta-analysis. And again, whether it was improved in dose dense or not. So in dose dense, it is improved with a hazard of odds ratio of 2.11, and when dose dense is excluded, it is further improved with a odds ratio of 2.7. So what we understand that if you are using dose dense, the benefit is slightly lesser, but it is still there. And if you are not using dose, then the benefit is even larger of adding platinum. Now, whether it improves EFS. Now, EFS is again one of the most important significant endpoint that we need to look into in this context, because EFS is the primary endpoint in most of the studies, including the two meta-analysis. The primary endpoint was EFS, and all these studies, the meta-analysis show an improvement in EFS and DFS. There was an improvement in PAT-CR, and EFS improvement again here is irrespective of the BRCA status, and same, the brightness and the JEPA-6 showed the same thing. Now, what about OS? Now, I want to say that OS is not a very significant endpoint when we are judging neoadjuvant chemotherapy or neoadjuvant systemic therapy, because it becomes the more important endpoint when you talk about adjuvant. And now probably the real debate should be adjuvant platinum or adjuvant carboplatin is a standard of care or not. There OS probably is a significant endpoint, because OS is multifactorial and significantly affected by the post-relapse treatment, the metastatic setting. So OS benefit, I would say that it is still there in most of the studies as well as in one of the meta-analyses, but it is not non-existent. It is non-consistent, but it is not non-existent. Now, this is the
Sir, your
EFS
time is up. Sorry to interrupt, sir. You had 6 minutes. You have taken 8 minutes.
Okay, just let me conclude. Give me 1 minute. So this is the EFS data of brightness, significant improvement seen. This is the triple negative breast cancer Indian study. And what was seen is in the women less than 50 years of age, there was a significant improvement of DFS as well as OS. This is the meta-analysis, significant improvement of EFS but the OS is not. And this is the AIMS meta-analysis showing both improvement in DFS as well as OS. And both in the dose and not doses. Now, what about safety? So what it shows is that there was only a slightly higher incidence of all grade 3 toxins, but grade 3 neutropenia, grade 3 thrombocytopenia, and febrile neutropenia incidences were not different. So the real toxicities are not different. And this is the forest plot of the meta-analysis, which shows that there was higher anemia and a slightly higher thrombocytopenia, but neutropenia, leukopenia, peripheral neuropathy, febrile neutropenia, they were not different. So the conclusion is that adding carboplatin has shown significant improvement in PAT-CR, EFS, and OS, and even OS benefit in many studies in one meta-analysis. This benefit is irrespective of the BRCA status, whether you are giving dose dense or not, whether with respective to whatever age and whatever is the tumor size. But obviously, when you talk about elderly age group and small tumors, it merits judicious patient selection. Guidelines endorse this, and it is safe, well tolerated, cost is acceptable. So I don't think there is any doubt why we should not think that this is not a standard of care. Thank you.
Thank you, Sir. Jodip Ghosh, next. No rebuttal time will be given to Dr. Vivek Agarwal if it is fine. Joydeep, sir, next to you, sir.
Are my slides visible?
Yes.
Yeah, go ahead.
Yeah. Okay. So thank you all for inviting for this debate. So I will talk in against the role of platinum. So yeah. So Vivek has nicely mentioned all the major studies. So I'll just take you through each one of these studies in my own way. So let us talk about the brightness trial. Okay, the brightness is an important study, we all know. It was Pacli Carbo plus Velipari versus Pacli Carbo versus Pacli alone. Nice design. All patients received anthracyclines. The primary endpoint was pathological complete response and not survival. Now, if you look at the trial, full text, you will see that the initial plan was to follow up for 10 years, but it changed to 4 years due to initial PATCR analysis. So my question is, was this hurried analysis, which is because of a statistical reason, wasn't it too early? Because we all know that small tumors do have a chance of recurring much later, which could have affected the overall survival and the disease-free survival. So are we concluding too early? Now coming to the slide, the survival curves. Now, Vivek has nicely shown the event-free survival of the brightness trial. I'll show you the overall survival. You will get a prize for, finding out the difference or a gap between the arms of this study. Anybody's guess? There is no difference in the overall survival. This was a well-designed study. Coming to another trial, the CalGB 4603, another famous study in this regard. So Paclicarbo plus minus BEV. If you look at the first publication of this study, a study whose primary endpoint is pathological complete response, in the abstract from PubMed, it starts off with toxicity. Patients assigned to carboplatin or BEV were less likely to complete chemotherapy without skipped doses, dose modification, or early discontinuation resulting from toxicity. Even the second line also reads regarding toxicity only. Only in the third line comes the primary endpoint. This is one of the rare situations where the primary endpoint comes in the third line. Okay. This is the overall survival. Again, no difference in the 5-year survival estimates between the arms. JPAR-62. We all know, famous study, a very complicated design. Nobody uses the standard of care, non-pegylated liposomal doxorubicin, bevacizumab. Anyways, for debate's sake, we'll discuss. So long-term follow-up showed improved DFS, but no improvement in the OS. But it used a non-standard chemo backbone. Nobody uses this kind of chemotherapy nowadays. It had a small sample size because if you look at the criticisms of the JPAR-62, it was not a fully designed study, or probably some authors said the sample size was much less. And the primary endpoint was not long-term outcome. It was not designed to look at long-term outcome, but anyways, they show some DFS benefit, but there was no improvement in the OS. Now coming to meta-analysis. Now this meta-analysis was done by Dr. Lambertini. Now people who treat breast cancer know what is the status or what is the stature of Dr. Lambertini. 9 randomized trials were included. There was no difference in the event-free survival or the overall survival. There was a significant higher risk of grade 3-4 toxicities. There was no increase in neuropathy, but definitely grade 3-4 hematological toxicities were a prominent problem. This is the DFS and the OS. They included the major trials, the CalGB JPAR-62. You can see clearly the diamonds touching the line of unity. So I don't need to mention that there was no difference in the outcomes. Now coming to our favorite TMH study. We all have our teacher Sudeep sir presenting this study. Clear-cut design, Pacli-Carbo AC versus Pacli AC. No confusion. Now, baseline stratification in this trial was menopausal status and stage. This was the result. The 5-year DFS was 70.6 versus 64.5, and the hazard ratio was 0.79. I have highlighted in red, it is crossing the line of unity. So the primary endpoint is crossing the line of unity. The secondary endpoint was OS, which was significant. Now coming to the subgroups, strangely, they mentioned that the benefit was confined to less than 50 years of age. Now I need to mention here that the median age of study median age of patients in this study was 48. So there was a significant statistical bias towards the majority of the patients falling in the less than 50 rather than more than 50. So this calculation was not pre-specified and it was a post hoc analysis. The trial mentions that there is a significant interaction between treatment and age. And addition of carboplatin had a significant beneficial impact on the overall survival. I agree. However, the primary endpoint was disease-free survival. Again, in an editorial in ASCO Post, you will see this is in public domain. Dr. Adam Brufsky, who is again a famous critic of breast cancer studies, he has clearly mentioned that the authors of this trial were not able to explain the basis of this result, and there were no other interactions with any other subgroups. So why just one interaction with less than 50, more than 50? That is also not pre-specified. So are we going to take the data of this trial without a pinch of salt? I will not. Now,
Your
my
time
friend,
is up, sir. I'm sorry
So
to interrupt.
you are left with the maximum 1 minute. Then we will close your talk.
So,
Sorry to say.
but sir, I'm taking even half the time of Vivek. Anyways, so this is a Cochrane meta-analysis. So I'll show you this is the most recent Cochrane meta-analysis. So primary outcome was DFS and OS. Secondary outcome was PATCR and all those things. So I'll just come to directly to the toxicities. Author's conclusion, there were more frequent dose delays and dose reductions, greater hematological toxicity. Now, this is the forest plot for the toxicity and chemo delays. You can see my friend has shown that there was no difference in toxicity in the TMH study. He has taken one TMH study. I have taken a Cochrane meta-analysis. Clear-cut increase in the toxicity. Again, clear-cut increase in the dose reduction. Now, we all know that dose reduction and dose droppage is not acceptable in triple-negative breast cancer. So what can we infer? Meta-analysis included trials which have many non-standard chemo backbones. So I don't know whether I'm happy with them or not. All the studies were powered for finding out PATCR and rarely for long-term outcome as a primary endpoint, excepting the TMH study. The TMH study has its own fallacies and too early to depend on the same based on the abstract. Toxicity is a major concern proven in meta-analysis by Cochrane. So as of now, we have very equivocal role of carboplatin in the NSCT setting, other than just increasing the PATCR rate. That also comes at the cost of dose modification and dose reduction, which is an integral part of breast cancer treatment. So my verdict is platinum is not the standard of care as of now in TNBC for NSCT. Thank you.
Thank you, sir. Over to Somani sir. Somani sir, you are mute, sir. Kindly unmute yourself.
Oh, as a customary, we would like to give 30 seconds back to Dr. Vivek Agarwal for rebuttal.
So I think, Dr. Joydeep has got it all right, because when we are talking about neoadjuvant treatment, we are chasing PATCR. And Dr. Joydeep has very beautifully not said a word about the keynote 522 data, but I frequently see, him prescribing immunotherapy to patients, in early triple negative breast cancer and using platinum blatantly while, when he's talking about the age bias, you must understand there's a natural bias. This bias is not created by me or anyone. Triple negative breast cancer occurring less than 50 years of age. So please, there is not bias in the trial. It is a natural bias. And he has not really talked from AIMS, which included a lot more trials, including the TMH trial, which was missed by the meta-analysis in Cochrane, as well as the Matteo Lambertini's meta-analysis. And this meta-analysis showed an improvement in both DFS as well as OS. So again, I'm saying you are not chasing OS when you're talking about neoadjuvant. You are chasing PATCR, and PATCR improves the long-term outcome that is known. And he's talking about recurrences in breast cancer after 4 years. I don't know what he's looking for.
Okay. So I am forced to stop you, Dr. Vivek, here, requesting you. Anyway, both of them has done a good job. And that's why in the very beginning, I said that please do not choose the two speakers from the same city if it's a debate sort of the things. Now,
don't mind my last slide. It was just for fun purpose.
so what I understood, if I have to conclude, that we need to divide these patients at the low risk versus the high risk. When we think of adding the drugs like the carboplatin or the platinum for that matter, the schedule, the duration is still controversial, not well settled. Toxicity is a concern. And there is a concern for the surgical delay also, which has been well versed in the many trials. And yes, there is a concern for the elderly patient also. Now, the first speaker sometimes talk about the PCR as the primary endpoint, but when he talks about the meta-analysis, he always say about the event-free survival and possibly the overall survival, contradicting his own statement. And overall survival, yes, still not proven. We say that the PCR improves the long-term outcome, but we say that the overall survival is still not there. Now, what about the second speaker? He talks much about the trials, that is the brightness trial, overall survival. Yes, he tries to say it's not there. Side effects, he tried to probably exaggerate it also. So what I would like to say, that keeping in the mind the low risk versus the high risk, and especially when you want to have the PCR as your primary objective in treating individual patient, like young patient, down staging, breast conservation, and when you feel that the burden of the disease is too much, then probably these are the suitable patients where you would like to add something more along with the taxane. If the immunotherapy is not there, if the BRCA opportunity is not there in the adjuvant setting or something like that. So I would like to conclude that yes, it is not standard of care for each and every TNBC patient who are going for new adjuvant treatment upfront. Thank you, and back to organizers. More discussion you can put in the chat box.
Thank you so much, sir. Wonderful discussion. We are running short of time, so we will quickly move ahead to the next topic for the day.
So can I share my screen?
So the next topic is on panel discussion on hormone receptor positive breast cancer. Moderator is Dr. Saurav Kumar Mishra from Bhubaneswar AIIMS. Sir, over to you.
Yeah, just.
Thank you so much. So in the meanwhile, I will invite the panelists for the discussion. Dr. Sachin Sekhar Bishwal, are you there, sir? All
Yes,
the
ma'am.
panelists kindly.
I'm back.
Thank you.
So should I share my
Yes,
screen? Okay.
sir.
Done.
So you can call to your panelists, sir. Thank you, sir.
Fine. So let's start the discussions. So basically, we are discussing today about hormone receptor positive breast cancer. And mainly we will be discussing neoadjuvant and adjuvant strategies. Thanks, organizers. So my first question is to our pathologist. Subhasis sir, you are there?
Yes, yes.
Yeah. So basically, can you please explain to us about the estrogen receptor and the basically receptor status in breast cancer?
Usually the hormone receptor positivity is mostly considered as ER positivity. So now the ASCO-CAP guidelines say that it is any receptor nuclear positivity more than 1% is considered to be positive. Less than 1% or 0 is considered as negative. So that is another subgroup in the ER positivity, that is low positivity, that is considered as 1 to 10%, which is of nuclear positivity in between 1 to 10%, and it should be given a comment that these hormone receptor positivity may benefit from the adjuvant therapy, but however the molecular and genetic profile may correspond to the total ERPR HER2 negative, triple negative breast cancer. So and the ER positivity breast cancers usually low grade tumors, and they are of
morphological type corresponds to that of the tubular or lobular carcinoma, or to that of the solid encapsulated
So,
papillary.
Subhasis sir, just to interrupt you, I think you have made a very valid point. We have to categorize now that ER positivity, which is 1 to 10%, is low positive. That has to be mentioned, right?
Yes,
Because
yes.
they behave in a different manner. They are not very endocrine sensitive. That means adjuvant endocrine therapy, the benefit is doubtful in this setting. And
Yes.
still, we would like to give in this setting. So please tell us something about the PR positivity, progesterone receptor positivity, Ki67.
So PR positivity is same, corresponds to that of the ER positivity, but this low positivity is not counted in PR positivity. Anything, any nuclear positivity more than 1% is considered as PR positivity.
Okay. Thank you.
And Ki67 in ER and PR positivity is usually low. It is less than 15% usually.
So I'll now go to my clinicians. So Dr. Sachin, are you there?
Yes, yes, sir.
Yeah,
Am
so
I audible?
Sachin, basically tell me what is the implication of the PR status in the presence of a ER positivity, or what is the significance of progesterone receptor in the hormone receptor status?
Good evening. ER is what we take estrogen receptor as both a predictive and a prognostic marker. But PR is a predictive marker only in the presence of ER positivity. So if a breast tumor is ER negative and it comes as PR positive, then we think again what might be the behavior. And as there is sufficient data to treat PR positive patients with hormone therapy, we go ahead and give them the benefit of endocrine.
So basically, ER positive, PR positivity do better compared to ER positive, PR negative, or ER negative, PR positive, right? That's what you are saying, Sachin, right?
Yes.
Fine. So next, Gautam. So in this current era, we have a lot of options for adjuvant therapy. So would you like to do a Ki67 in this setting? And if yes, why?
Yes, sir, because Ki67 basically indicates the aggressiveness of the disease, and though olaparib is not currently approved for those patients, we may discuss with the patient if it is Jamla and BRCA positive.
Okay, so it's mainly Ki67 as per the Monarch E study. If we have a Ki67 of more than 20%, that is one of the risk factors in combination with node positivity, where these patients become eligible for adjuvant abemaciclib. So yes, Ki67 plus the classification into luminal A and luminal B, right? So again, coming next to Sachin. So basically, now we have a category known as hormone receptor positive, but which is HER2 low, that is IHC 1 plus or HER2 2 plus and FISH negative. Would you like to know about this result also? I mean, the HER2 low status also, would you like to know that in presence of ER positivity?
In presence of ER positivity and early breast cancer, HER2 low, as of now, I don't think have any implication for treatment.
But in the metastatic setting, yes, right? In these patients, you can give TDX. Perfect. So now we go to the indications for neoadjuvant chemotherapy in hormone receptor positive breast cancer. So Gautam, you can take it up. How do you decide on the role of NACT?
Sir, basically, NACT is given for ER positive patients, basically for breast conservation, if it is not feasible for breast conservation, or if the patient is not fit for a surgery upfront, then also it can be given. As such, there is no additional benefit of NACT compared to adjuvant chemotherapy.
Perfect. So what would be the regimen, if at all, you would be using?
Sir, it will be
AC and taxane, right?
AC followed by taxane.
Perfect. So there is some data to show that nab-paclitaxel, it improved IDFS in hormone receptor positive subset in the JEPAR-SEPTO trial. So Gautam, Sachin, you can take it. Neoadjuvant hormone therapy, in which patients you would be using in your clinic mainly?
Neoadjuvant hormone therapy has definitely some role in neoadjuvant setting, especially while selecting patients who are very elderly, have poor performance status, not fit for chemotherapy, like those patients. And there is some data that the breast conservation rate with neoadjuvant hormone therapy reaches up to, it is similar to with what we achieve with neoadjuvant chemotherapy.
So
But
as far as
apart
possible, yes, as far as possible, we give chemotherapy because of better responses. But if at all, as all these conditions you are saying and HER2 also negative, you can consider neoadjuvant hormone therapy. Perfect. So anthracycline-free regimens in hormone receptor-based cancer, how do you choose on the use of anthracyclines? So basically, anthracyclines, yes, we can take it from Sachin and Gautam, your opinion.
Anthracyclines, we always prefer if the patient is fit for anthracycline, then we always try to give anthracycline because there is clear survival benefit of it in the meta-analysis mentioned. And if the patient is not with any cardiac comorbidity, in that condition, we try to avoid. And if it is early breast cancer, like somewhere we have to decide with the help of recurrence score that this patient needs or does not need chemotherapy, in that subsets also, we can, in some cases, avoid analysis.
So Gautam, in which patient
Yes.
would you use this regimen, docetaxel and cyclophosphamide?
So, sir, these are basically HR positive, node negative, and basically T1 to T3 diseases. And apart from basically DC, we can also use TMF also in those patients who are basically compromised cardiac functions, basically.
So basically, DC is better than only AC, and DC has been found to be non-inferior to AC and taxanes based on these studies.
Yes.
So at least we have an option here for our patients, right? Sunil, are you there?
Yeah,
Sunil,
I'm there.
Dr. Sunil Jaiswal. Yeah.
I'm there.
Sunil, please tell us. Yeah. So basically, patient has received neoadjuvant chemotherapy, and in a hormone receptor subset, LABC. Just tell us about briefly surgical principles, and has there been anything new? You can just tell us.
Mostly the
They're not able to hear you, Sunil.
Remain almost the same. We have two
Okay.
principles. The one part. Hello, am I audible?
Yeah. Please tell me.
Hello.
Yes, please tell
So
me. You are
basically, the
audible.
surgical principles almost. Surgical principle almost remain the same. We have to give a good oncological clearance. Whether we are doing a BCS or a MRM, the surgical principles are the same. There's some controversy regarding doing a sentinel lymph node biopsy in post NACT setting, but the data that we have, we can safely do as per the data that we have. So doing a sentinel lymph node biopsy in a node negative patients remain almost the same. But if the patient had a node positive proven disease before the chemotherapy, then
Okay. So I think it's very clear that the surgical principles are almost the same in this setting. So we will now come to the role of adjuvant radiotherapy. So Subhasis, what are the indications of adjuvant radiotherapy in the hormone receptor positive setting? Could you please elaborate guidelines?
Yes. As we know, in case of in case of adjuvant setting, if we are saying, we are just focusing on the adjuvant part, post-op adjuvant cases, those T3 or more tumor size, and if node positive, then as usual, these are the indication for adjuvant RT. The next part is in case of there are basically three scenarios if we can divide them. First is the upfront post MRM cases or post NSCT, then surgery is done. Then surgery is whether it is MRM done or BCS done. Accordingly, RT is to be designed. So RT portals, if we say, first of all dose, then the hypofractionated regimen is almost the norm now. The 40 or 42.5 in 15 to 16 fraction. And the boost part in case of BCS, another 10 to 12.5 gray is given as boost. So the area of coverage, generally we cover the chest wall if it is a MRM case, and the supraclavicular area. Axillary dissection, if it is done, then we don't include the axilla. If it is a BCS case, then the whole breast radiation followed by boost to the tumor cavities given. So ये receptor wise no specific change in irradiation guideline. Normal radiation indications are to be applied in this case.
Fine. Thank you, Subhasis. So now let's come to the recurrence score in early breast cancer. So in which settings is recurrent score used? We have our molecular oncologist with us, Dr. Amit Barma. Are you there?
Yes, I'm here actually. So,
Yes, sir. So basically, sir, can you please tell us your experience in these? What has been the Indian experience of this recurrence course? You are doing this, in which patients you do, and
so patients mainly
results you can please tell us.
Yeah, so the patients who are not keen for the chemotherapy, those are the first priority for us to investigate whether they are really, we should push them further for chemotherapy or not. So normally we try to divide the patients between the age less than 50 and more than 50, and early breast cancer, that is stage 1, stage 2, and also lymph node positivity up to 3 nodes positive. So if we see that the patient clinical risk factors are favorable, now the question comes, should we be aggressive in terms of giving chemotherapy or not? And if the patient is denying upfront when there is no discussion about chemotherapy, then these recurrence courses are not recommended. On the other hand, if they are keen to know more about it, we recommend a couple of options. We have two major important options. What we are offering these days is Oncotype DX and Mamapen. If the patient cannot afford, we have Indian version that is scan assist. So we have different scoring method for recurrence scoring. Basically for young patients, the cutoff score goes different as compared to more than 50 age group for Oncotype DX. Anything above 16 for younger patients, we recommend that the patient should be offered chemotherapy. If it is more than 50, the cutoff is 25. You can give chemotherapy in that case. Low risk and intermediate risk, respectively, for less than 50 and more than 50 is 16 and 25. So in that case, we can give the option for patient to give adjuvant hormonal therapy alone. Having said that, patients who are node positive, who are keen to avoid chemotherapy, there is a substantial subset, maybe up to 30% patients may not require chemotherapy and may get benefit of using all these risk scoring approaches actually. But the clinical judgment has to prevail. We have to correlate various other factors, and always a cost also becomes a very important discussion while we discuss with the patient. So it is a informed and a consensus between the patient and the doctor actually.
Definitely, very clearly said. Although these are costly investigations, we have seen that there are results based on these chemotherapy you can forego for many patients. So definitely these options would be given. Now we would be having CAN-assist discussion also, which has been found to be really good with very strong Indian data. So we should offer these tests for our patients, for the eligible patients, especially in whom we would like to avoid chemotherapy, node negative patients mainly, although there is data for up to 3 positive now. Now, menopause is a very important status here. So menopause is defined something like this: bilateral oophorectomy, age or equal to more than 60 years. If less than 60 years and amenorrhea more than 12 months, we should hand on prior chemotherapy or hormonal therapy. We should do a serial FSH and estradiol measurements. And if serially we find that the estradiol is low and FSH is high and in the postmenopausal range, of course, these are all lab-related parameters. We should take it with a pinch of salt. But you should see consistently, if you see that they are in the postmenopausal range, probably these patients are having a menopause. Now I'll come to the last part of my discussion. So basically, there are a lot of options for additional adjuvant therapy. As we saw, Chandrakant presented, these patients are going to relapse. There are subset of patients node positive who are definitely going to have a recurrence. So all these things, what we are doing for additional adjuvant therapy, it's predominantly to say that we want to decrease the recurrence rate, improve the survival. How can we do it? For the paucity of time, I'll not ask any of my panelists. We have already engaged them. I'll just read it out and we can call it a day. So soft and text trial, we have to incorporate ovarian function suppression. Monarch E, you have to add adjuvant abemaciclib. DFS results are good. Graphs are separating. Natalie, still early. And adjuvant abemaciclib, we have 5-year data now. IDFS benefit is seen here. Olympiad. Some of these patients who are having germline, those patients who have received neoadjuvant chemotherapy, hormone receptor positive, but not attained PCR, or if they have received adjuvant chemotherapy node positive with clinical pathologic stage estrogen receptor grade more than equal to 3 CPS-EG score, benefit from olaparib. So yes, germline BRCA mutation should be done. How long should be the adjuvant therapy? 5 years is must. But of course, there is data now that for low risk subset of patients who are like less low node positive or node negative and smaller tumor size, you can go for 7 years, which is almost similar to 10 years of adjuvant therapy. For larger tumors with node positive, you can go for extended adjuvant aromatase inhibitors mainly. There is improvement in overall survival data with that. Adjuvant denosumab, it will decrease the bone metastasis incidence, but doesn't have a benefit on survival. Joletronet, however, DFS and OS benefit. So some patients considering risk benefit might be offered joletronet in the early breast cancer patients. There was a study from yoga and also from outside that doing yoga during the patient when they are receiving chemotherapy improves the quality of life, which is very, very important. Most of these patients develop some toxicities. Obesity worsens the overall survival. So weight reduction is also an important thing to discuss. So having said that, I would like to conclude. Thank all my audience. If there are any questions or comments, welcome. Thanks once again.
Thank you so much, Saurav sir. You have really saved the time and
sorry for connection issues.
help us manage further.
Thank you, everyone. Thanks a lot. Thanks. So I can
No
stop
problem.
sharing.
Oh, thank you so much, all the panelists. Thank you so much, Saurav.
Thanks.
Sir, thank you. We will move ahead to the next sessions immediately because we have paucity of time. If anybody does not have any questions further to Saurav, shall we move ahead?
Yeah, let's go ahead. They're all knowledgeable people.
So next topic is by Dr. Sir. Again. Next topic is by Dr. Manjari Barke. Madam. Talk is diagnostic hand for early breast cancer. Doctor.
Garima, switch off your video and speak. Switch off.
Sir. Dr. Manjari, madam, are you there? Yeah.
See,
welcome, madam.
Right. Yeah.
Yes. Yeah. Thank you so much.
So
thank you all for having me. Let me start the presentation. Yes. Okay. Good evening, everyone, and it is indeed my pleasure to be part of IAIO chapter. And today talk. Can you hear me, please?
Yeah, ma'am. Please go ahead, ma'am.
Okay, all right. So the title of my talk is Can Assist Breast, a Useful Prognostic Tool in India. And as Dr. Mishra just gave the background, thank you, Dr. Mishra, for the same. So the dilemma that you all know is clinical dilemma in treating hormone-positive, HER2-negative early breast cancer patients is which patients will have good prognosis and with endocrine therapy alone. And on top of endocrine therapy, which patients would benefit from taking chemotherapy. Prognostic tests, tools, markers help clinicians to identify these patients. Genomic prognostic tests are well known: Oncotype DX, MammaPrint, EndoPredict, and Prosigna. However, all of these genomic platforms were designed for prognostication of risk of relapse in uh, uh, um, uh, Caucasian patients. The development was based on Caucasian patients. Their validation studies have majorly Caucasian patients, higher age group, who have a disease at a higher age, postmenopausal age. They often have smaller tumors, screen detected, lymph node negative, and Asians are underrepresented, under 8%. Kevin Kalinske, the primary author, first author of the RxPointer trial, has himself said this: the tumor biology such as proliferation, gene groups, and may differ by race and contributing to noted disparities. It has been known that the Oncotype DX risk score doesn't perform equally well across different ethnicities. And this has also been published to showcase, more importantly, that the Oncotype DX 21 gene recurrence score does not is not predictive for Asians. There is no significant reduction in the risk of death with adjuvant chemotherapy amongst Asians and Pacific Islanders with in high risk, as well as in the late towards the end of the low risk 11 to 25 risk score. So if you wonder for a minute why that could be, the reason lies in the way this appears in Asians versus Western breast cancer patients. In Asians, it is the onset is premenopausal versus postmenopausal. The tumors are patients are diagnosed with slightly higher tumor burden, primarily one lymph node positive patients, as against screen detected small tumors, lymph node negative tumors, and ours is often stage 2 disease where they get diagnosed in stage 1. So essentially, our problems, which could be, which is why the Western tests don't work on our patients, could be disease onset at a younger age, and disease which is mainly node positive, grade 3, high Ki67. So we really require a prognostic test that would encompass the tumor biology of our patients. And that was really the prime reason why we wanted to develop CAN-Assist Breast. So CAN-Assist Breast is developed on Indian patients' tumor tissues. What is it? It is a prognostic test which uses immunohistochemistry as a platform technology. It looks at 5 different biomarkers, protein biomarkers, which are involved in metastasis. Those are performed on a Roche's automated Ventana machine as IHC and then graded by trained oncopathologists in our lab. That information, along with the 3 clinical parameters, tumor size, tumor grade, and the lymph node status of that particular patient, goes into our proprietary machine learning based algorithm to give a risk score, which is the number between 0 and 100. And if the risk score is under 15.5, a patient is considered to have a low risk and treatment can be planned accordingly. And patients with risk score beyond 15.6 are considered to have high risk. This test, CAN-Assist Breast, is validated on close to 4,000 patients in not only in India, but in US and also in Europe. It has high accuracy, negative predictive value of 95% at par with the Western test. Patent for the 5 biomarkers is granted, and we have several peer-reviewed publications. What are those 5 biomarkers? People often assume it is ER/PR, HER2, Ki67, but those are not the biomarkers we look at. We look at CD44, 2 cadherins, and 2 ABCC transporter proteins. CAN-Assist Breast, as I mentioned, has been validated in global studies. We have maximum sites, of course, in India, and then in not only in US, but in Spain, Germany, Italy, Austria, and the Netherlands. Now, coming to the data of this test. So this is the overview of the entire data that we have. CAN-Assist Breast generates actionable risk group. So if you look at the left side Kaplan-Meier graph, in which we have plotted distant metastasis-free survival against time in months, you can see that the patients treated with chemoendocrine therapy, CAN-Assist Breast is able to segregate them into low risk versus high risk, about 70-30. The low risk patients do enjoy a higher DMFS, distant metastasis-free survival of 94% as against the high risk. And one can argue that some of these patients got benefit of chemotherapy. So we also did subgroup analysis of endocrine therapy treated patients alone. And even here, CAN-Assist Breast segregates those patients into 2 risk categories in a statistically significant manner. The lower risk patients have a higher DMFS of 95% versus the high risk patients who have a lower DMFS of 84%, indicating CAN-Assist Breast does segregate patients irrespective of use of chemotherapy. All of this data that I'm going to showcase today is published in 12 different scientific international peer-reviewed publications. What about the reach of CAN-Assist Breast today? So we have been in the market for Can-Assist Breast in clinical use for last eight years. Can-Assist Breast is being used by more than 400 doctors, not just in India, but also in Turkey, UAE, Sri Lanka, Bangladesh on more than 5,000 patients. 75% are typically low risk. Can-Assist Breast is reimbursed by multiple insurance, healthcare insurance, private as well as public. And Can-Assist Breast is also included in Asian Geriatric Oncology Society's guidelines. Until from 2016 to December 2023, we have done close to 5,000 patients. Majority patients for whom Can-Assist Breast was used to plan therapy were T2 tumors. Majority were lymph node negative patients, 82%, and majority were G2 disease. Our real world NPV is 97.6, which is even better than the predicted NPV. Now coming to how does it really help you in your day-to-day treatment planning, OPDs. So often you would be relying on these parameters, that is TNM, the grade, age of the patient, and Ki-67 as a guiding tools, guiding principles to decide on use of chemotherapy. Based on that, you would consider them as clinically low risk or clinically high risk. But then it is quite possible that if you focus on the clinically low risk, that you have low risk, low Ki-67, T1, T2, N0, postmenopausal patients. These are standard clinically low risk, but there may be some high risk tumors amongst them based on the tumor biology. And can you find these patients using Can-Assist Breast to escalate treatment for these patients? So if you look at, this is the data that I will showcase now. So if you look at Can-Assist Breast-based risk stratification in low Ki-67, these are considered clinically low risk. If you look at them, this is Ki-67 between 0 and 5%, whether patients were treated with chemoendocrine or endocrine therapy alone. Can-Assist was able to find, segregate these patients into low and high risk. And the high risk patients were 12 to 19% patients who had a lower DRFI, distance recurrence free interval, of 84 and 86%, indicating tumors with low 67 can still have aggressive tumor biology, which Can-Assist is able to find because it goes beyond proliferation. Next is the typical clinically low risk patients who have a low tumor size, T1 or T2, and a lymph node negative. If you can see, even in this patient population, Can-Assist Breast, whether patients were treated with chemoendocrine or endocrine therapy alone, Can-Assist is able to find the high risk patients of about 10 to 13% who have a lower DRFI, and they would benefit by escalating, so they have a higher risk tumor. So you not only need chemotherapy, but maybe something else as well. So this was the total patient data. So many of you have asked us, what about Indian patients data? So we specifically looked at the Indian patients data, patients with low clinically low risk T1, T2, N0 disease, treated with CET or ET alone. And you can see again, Can-Assist is able to find these 14 to 16% patients who will benefit from adding chemotherapy. Some of you even asked us, can you show us the chemo benefit data? So we looked at the analysis here differently. We looked at the data differently. We looked at all the patients who were Can-Assist Breast low risk versus high risk. In the Can-Assist Breast low risk, whether or not you add chemotherapy to the treatment regime, to the treatment planning, there was no benefit, because statistically non-significant. But Can-Assist Breast high risk patients, if you omit chemotherapy, just give endocrine therapy to these patients, they tend to have a recurrence. So this goes to show that in clinically low risk patients, there is benefit of chemotherapy only in Can-Assist Breast high risk disease. So not in the Can-Assist Breast low risk disease. What about postmenopausal node negative patients, G1, G2 disease? These are again considered clinically low risk. But once again, if you see, Can-Assist is able to find about 20 to 30% patients as high risk who have a lower DRFI of 84 to 85%, indicating these patients, although they consider clinically low risk, they definitely are of high risk. They are recurring more, they have a lower DRFI, and therefore can be treated in a better fashion. So just to summarize the data so far, Can-Assist Breast is able to find high-risk patients in clinically low-risk disease. And these are the percentage of patients who are actually clinically Can-Assist Breast high risk. That is, whether they are T1, T2, Can-Assist is able to find these many percentage of patients who are actually at high risk for distant recurrence. And that is proved by the fact that they have a lower DRFI compared to the Can-Assist Breast low risk. Now, I'm going to switch gears. Sorry, yes. Look at the patients who have a clinically high-risk disease. Can you find patients who have a low-risk tumor in this? Are they all clearly clinically high risk? Or do they have a higher risk of distant recurrence? So node-positive disease is often considered as a high-risk disease. But you can see here, CanAssist is able to segregate these patients and is able to segregate the low risk and high risk. The low risk node positive patients have a higher DRFI of 91%. What about, this was at 5 years. What about at 10 years? Even at 10 years, as per team trial, we have shown that the DRFI at low risk for 10 years in node positive disease is at 87%. What about patients under 48? The premenopausal patients, even in endocrine therapy alone, under 48 year treated patients, 23% patients were high risk, and the remaining 87% had low risk with 94% DRFI, which is excellent. What about patients with under 48 premenopausal and lymph node positive? Yes, there is still 46% patients who have a 91% DRFI. They will do well, even without excessive chemotherapy. What about patients really young, under 40 years? Yes, there is a definite population of 38% patients who actually have a worse disease, and they can be treated with additional therapies apart from chemotherapy, maybe ovarian suppression, etc. Patients who are over 48, you can maybe a 65-year-old who has N1 disease, is she at high risk or low risk? CanAssist is able to segregate them. The low risk have a better survival, the high risk have worse survival. So they are able to segregate, CanAssist is able to segregate patients essentially based on the underlying tumor biology. And therefore, these patients can get either de-escalation or escalation of therapies to reduce toxicity and optimize therapy. And why do we believe why this is working? As Professor Cliff Hadis has written this excellent editorial a few years ago, CanAssist based biology before anatomy. We believe CanAssist based is able to understand the underlying tumor biology in great detail beyond proliferation, and therefore it's able to find the high risk patients or low risk patients in otherwise clinically low or high risk disease. So the recent updates is CanAssist based we have standardized to perform on core needle biopsies as well as surgical specimen. We have an excellent concordance of 97.5 between core needle biopsy and surgically excised tumor tissue. CanAssist based also helps in multicentric tumor. All of this is under review. So the publications will come out soon. And I would like to stop here and take questions. Thank you all for listening to me.
Thank you so much, Manjari ma'am. Excellent talk and good summary. We've all been also practicing the prediction tools, and CanAssist is one of the best and most commonly used with us as well. Thank you so much, Manjari madam.
Thank you so much for having me.
We will quickly move ahead to the next debate if there are no further questions. The next session is next talk is on the debate. The debate is on TDX1 is the first option in HER2 positive metastatic breast cancer with brain mets previously exposed to trastuzumab. For Dr. Manoj Mahajan will be talking against Dr. Shrigopal Mahanti. An expert opinion is by our respected Dr. Raghunathan Rao sir. Sir, welcome, sir.
Yeah. Good evening, everyone.
Good evening,
We are here to discuss the latest antibody drug conjugate trastuzumab deruxtecan in brain metastasis in patients who are previously treated with trastuzumab for metastatic breast cancer. To set the ball rolling, we need to understand that the CSF penetration of the common drugs or regimens which we use in breast cancer, which is HER2 positive, is the TCH regimen or PCH regimen. If you don't want to use Taxotere, you may use Taxol or paclitaxel. So paclitaxel has just 1% CSF penetration. Docetaxel has 8% CSF penetration. And carboplatinum has just 2.6% CSF penetration. And then what about trastuzumab? Does it penetrate? No, it doesn't. The normal brain has very little trastuzumab. In fact, the partition coefficient is 420:1. If you have leptomeningeal disease, it may drop to 76:1. And if you add radiation to the brain tumor, it will drop to 49:1. So in this context, we would like to have the debate of what's the role of the antibody drug conjugate of trastuzumab deruxtecan in those patients with metastatic breast cancer who are already treated with trastuzumab for their disease. So to talk for the motion is Dr. Manoj Mahajan. So I invite Dr. Manoj Mahajan first, and against the motion is Dr. Aditya Prakash. So we will go ahead and take the first for the motion with Dr. Manoj Mahajan.
Sir, Dr. Manoj Mahajan is not available right
Okay.
now. So he has sent a recorded video. We would like to play that. Is it
Sure,
okay?
please go ahead.
Thank you so much, sir. Kindly play the video.
Good evening, everyone. First of all, I would like to thank Dr. Vishwas sir for giving me the opportunity. So today's topic of debate is TDXD is the first option in HER2 positive MBC with brain metastasis and patients, especially those who are previously exposed to trastuzumab. So we'll look into the current standard of care, what were the past results, and what are the future prospects in such subgroups. Next slide, please. So if we look at the overall incidence of the breast cancer in Indian setting, it's around 2 lakhs per annum. 1 in 29 is the cumulative risk. Next slide. So if we look at overall hormone receptor positivity is around 2/3, and remaining 1/3, few patients around 10% are HER2 negative, and rest are around 15 to 20% patients are HER2 positive. Next slide. So if we look at overall survival of patients in HER2 positive MBC in last 2008 to 2016, there is almost doubling of the overall survival period. To be precise, 39.1 months at the end of 2008 to up to 2016, it was not reached. If we look at the graph, the latest graph is extending beyond 12 years. Next slide, please. This is the main diagram where we can see there are certain molecules who act on the extramembranous cellular part. Some are acting intracellularly, intramembranous part, and some are intracellular, cytoplasmic, or nuclear. And if we look at various targets, if we combine all these three levels, then we get the much better results that we can see in the future prospects are currently approved in USA, tucatinib, capecitabine, and trastuzumab. So I think that is a wonderful diagram. Next slide. So current standard of care is in first line, taxanes are combined with the anti-HER2 agents for 4 to 6 cycles and subsequently maintenance. In second line, there is a discussion between non-brain metastatic patients, TDXD is the drug of choice, and for brain mets, tucatinib, capecitabine, and trastuzumab is the drug of choice. But in Indian's current scenario, it is not available. So obviously, it becomes TDXD as a drug of choice in second line and onwards subsequently. Next slide. So this is the crux of today's talk. If we look at various trials where all the drugs who penetrate CNS has shown their overall response rates and median PFS. So the tucatinib, if we look at the standard of care, the overall response rates is around 50% and median PFS of 9.9 months. Vis-a-vis, if we look at the Destiny trials, Destiny 1, 3, the response rates are to the tune of 60% or more than 60%, and median PFS is 18.1 months and 15 months, which is unheard of in any of the other drugs. So probably in current scenario also, TDXD is the drug of choice even in brain mets, and only drawback of this is small number of patients. Next slide. So after trastuzumab, what was the initial choice earlier, which has shown like TDM1 was the one of the choice, which was established in Emilia and Theresa trials, which established some activity in the CNS. Next slide. So if you look at the Camellia study, TDM1 in HER2 positive breast cancer with brain metastasis, overall response rates in the cranium was 21.4%, CBR nearly 42.9%. So this was the drug which paved the path for brain metastatic patients beyond trastuzumab. So TDM1 was one of the choice, but now we'll see the subsequent slides. What is the current evidence? Next slide. To support the Indian data for TDM1, the PFS was around 10 months, OS 27 months, and this population included nearly 28.7 brain metastatic patient. Next slide. So how does TDM1 and TDXD differ? The most important points, what I feel was drug to antibody ratio 8:1 as compared to 3.5:1, and the bystander effect and the tumor selectivity cleavable linker. So these are the three parameters where TDXD exceeds as compared to TDM1. Next slide. So what is the supportive evidence for this statement? So if you look at the Destiny 1, 2, 3 trials, the pooled analysis of TDXD pool, which can show the brain metastatic patient of nearly 150 patients, and comparator arm has nearly 83 patients. So the endpoints were intracranial overall response rate. This was a retrospective exploratory pooled analysis. Next slide. So if we look at the results, nearly 45% patient has complete response or partial response. And if we combine that with the stable disease, again, it doubles to nearly 90% for the stable disease as compared to the comparator pool, which was much lower as compared to TDXD. Next slide. So if we look at treated stable brain metastatic patients, the median PFS 12.3 months versus 8.7, and untreated or active brain mets 18.5 versus 4 months, with hazard ratio of 0.19, that too in CNS. So it is quite impressive to have such hazard ratio in this situation. Next slide. So TDXD is showing the quite good activity as brain metastasis patient also, that we can see from this diagram. Next slide. So looking at the HERCLIMB, the overall survival in with the tucatinib, the future drug or the drug which is approved by USA, the median OS of 21.6 months versus trastuzumab combination of 12.5 months. And at the end of 24 months, 25% versus 48.5%, nearly half of the patient at the end of 2 years were surviving with tucatinib trastuzumab combination. So this is the drug which we need to look for. So overall, this slide is depicting overall CR and PR of 26 versus 4%. Next slide. So if we look at the flow diagram or algorithm, we can see the first line is remains taxanes plus trastuzumab combination. Second line for visceral disease, TDXD. For active CNS disease, tucatinib is recommended, but it is not available in India. So obvious choice is TDXD even in CNS metastasis. So currently the first drug of choice in Indian setting is TDXD. Next slide. So these are the future molecules where we need to look into, and CNS rates, response rates, and PFS has improved with these two molecules. So we are looking forward more additional improvement in such with addition of these all molecules. Thank you.
Thank you for the wonderful presentation, Dr. Manoj Mahajan. I know you are not there and we saw only your video, but that's a wonderful presentation. Crisp and to the point. So let us hear the rebuttal or the motion against by Dr. Aditya Prakash. Over to Dr. Aditya Prakash.
So Dr. Sri Gopal actually, sir. Dr. Sri Gopal Mahanti.
Dr. Sri Gopal
Okay.
Mahanti, sir.
Okay, okay. Please go ahead, Dr. Sri Gopal. Dr. Mohanty, please go ahead.
Sri Gopal, can you
unmute
yourself?
Yeah. Madam, can you please share the slide from my side?
Anita,
yes, sir. Sharing the screen. Just a second, sir.
Sri Gopal, your screen is green. I think you can switch off the green screen.
Yeah, okay. Sure. So, good evening, everyone. First of all, thanks, Ghanashyam sir and team IAO for giving this opportunity. So, I will be talking against the motion of the role of trastuzumab deruxtecan as a upfront option in metastatic breast cancer with CNS metastasis post progression to trastuzumab. Next, please. So this is the way basically how this breast cancer brain metastasis happens, that the invasive breast cancer cells that reaches the basement membrane. Next slide, please. Next slide, please. Oh, yeah. So invasive epithelial cells that breaches the basement membrane and reaches goes to the systemic circulation. There it undergoes extravasation and finally it penetrates the blood-brain barrier, which is made by endothelial basement membrane, astrocytic basement membrane, and the pericytes. So then subsequently develops into CNS metastasis. So next, please. So if you look at the post-trastuzumab era, so the rate of CNS relapse has come down significantly. So 1 to 2% of early breast cancer actually relapse at CNS site in this post-trastuzumab era. If we see the post-trastuzumab neoadjuvant therapy, if any invasive residual disease is there, there is a chance of little bit higher CNS relapse to the tune of 5%. So in this HER2 positive metastatic breast cancer, we can have 30 to 50% chance of CNS relapse compared to other molecular subtypes. So 30% particularly roughly in receptor positive HER2 positive subsets, and receptor negative HER2 positive subsets, it can go up to 50%. So we have anti-HER2 drugs with promising CNS activity like trastuzumab emtansine, tucatinib, and trastuzumab capecitabine combination as per the HER2 claim, and trastuzumab deruxtecan. So my question is like which drug is having better efficacy and how to sequence these drugs. So let's see the expert consensus recommendation so far. So next, please. We can see this paper from Duke Cancer Center, US. So they have looked into these subsets of patients with brain metastasis. They found if there is any solitary brain mets, we can do a upfront surgery followed by post-surgery radiation to the brain metastasis, or else we can go for radiosurgery. If we have a limited number of CNS mets, we can go for radiosurgery alone, or if we have a diffuse brain metastasis, parenchymal metastasis, we can go for whole brain radiation along with hippocampal sparing or using memantine to reduce the neurocognitive deterioration. So they basically focus on the local CNS directed treatment, either surgery or radiation, then only followed by that systemic therapy. So in that way, we can reduce the permeability, like the blood-brain barriers. Actually, we can breach the blood-brain barrier, and then the role of systemic therapy. So in systemic therapy, as we know, the first line option is taxane plus trastuzumab plus per2. Second line is trastuzumab emtansine. Third line, they have recommended other like HER2 claim or the trastuzumab deruxtecan and other regimens. So next, please. This paper again from Germany and Italy. They have, next please. So they have also agreed to the previous consensus that first we have to focus on the local CNS directed radiation or surgery. So followed by systemic therapy. In few of the selected cases, young, very fit patients without any, CNS symptoms, still we have an option to go for systemic therapy, but that subset is very limited in our population also, and as per their consensus also. So next, please. Among the systemic therapy, we have options for this all deruxtecan or emtansine or tucatinib with trastuzumab capecitabine. So basically, next slide, please. So this is again the similar paper from the Dana-Farber Cancer Center, US. So next, please. So they have also agreed to the previous statement that if any HER2 positive brain metastasis cases with a fair prognosis, first treat with local therapy, then systemic therapy. They are writing systemic approach in addition to local approach. So always they prefer upfront local approach, then only they go for systemic therapy. So systemic therapy after the local therapy. Once I will revise local therapy in form of surgery followed by post-op radiation. If it's a solitary operable case, if it's a solitary case, smaller size, then still we have option for stereotactic radiosurgery. If limited number of mets, we can go for stereotactic radiosurgery. Or if it's a diffuse parenchymal mets or it's a leptomeningeal mets, we can go for whole brain radiation along with memantine or sparing the hippocampus. So for systemic therapy, if post-local therapy to the CNS site, if there is no cranial, intracranial or extracranial progression, still there is an option to continue the previous systemic therapy, either trastuzumab combination or trastuzumab alone, or whatsoever, if at all any other anti-HER2 therapy we are giving. So in few cases, in selected cases with CNS progression or extracranial progression after the local therapy, we can change the systemic therapy backbone to either TDM1 or deruxtecan or tucatinib with combination with trastuzumab and capecitabine. Next, please. So this is again from the ASCO guideline. They also agreed to the previous three consensus in the same way.
1 minute for you.
Next, please. Next, please. So basically, whenever there is a progression either inside CNS or extracranial, there we have to change the systemic therapy option. Next, please. So look at this efficacy. In the first line, like upfront TDM1, we have a PFS data from Emilia 6 months, from Marine Trail it is 14 months, And if we use second line, the PFS is 5.5 months, almost about 6 months to 14 months. So for trastuzumab deruxtecan, it is PFS, upfront, if you use it 28 months. If you use second line, subsequent line, post TDM1 also, we have a PFS of 16 months, which is not very bad. So if you look particularly at the CNS PFS, when there is a stable brain mets, asymptomatic brain mets, the difference is not very big, 12 months versus 8 months. So 8 months with TDM1 and 12 months with TDXT. Whereas the difference is very big when we have a active brain mets on treated brain metastasis, which in our practice is very, very less. So next, please.
Time's
So
up, Dr. Gopal.
I will wind up. So limitations of TDXT is interstitial lung disease 15%, not very less. Drug discontinuation 20%, dose reduction 25%, drug interruption also more than 40%. So next, please. So why should we keep deruxtecan in the later line? It has a promising efficacy even in the subsequent line with a 16 month of PFS. It doesn't cause more toxicity when we use in the subsequent line. We can compare the Destiny Breast 001 and 003. Next, please. Next, please. So guidelines says sequencing of treatment. So to have a lesser toxicity, lesser financial toxicity also, and more quality survival. So we have multiple options post TDM1 as per the Destiny Breast trial 003 or be it HER2 climb. And this TDXT also not affordable for majority of our Indian patients. So next, please. So look at this, that TDM1 average cost per cycle is 75,000 to 1 lakh. Whereas if you look at NHER2, the TDXT, the cost is per cycle about 5.6 lakhs on average. And tucatinib per month cost is about 5 to 6 lakhs. So if you look at the cost effectiveness and sequencing the treatment, for me, this TDM1 is far a better option in our setting. So next, please.
Gopal, time is up.
Efficacious, cost effective, and first line in HER2 positive CNS metastasis in a breast cancer post trastuzumab progression. TDXT, I will reserve it for subsequent line of therapy, and particularly upfront, I will select in those cases with symptomatic CNS progression post local CNS directed radiation or surgery. Thank you.
Thank you very much, Dr. Mahajan, for that spirited defense against the institution of first-line treatment with deruxtecan. I agree about the toxicity as well as the financial toxicity. I'm sorry that we don't have Dr. Mahajan to rebut Dr. Mohanty's presentation, but I would agree that if you have a choice and you have an Indian substitute, like he has very clearly shown as Ujvira, you would possibly try to use TDM1 as first line and reserve this as a subsequent treatment, since that seems to work very well after the failure of Emsantin. With that, I hand over the proceedings back to Dr. Garima, and thank you very much for allowing this debate on first-line treatment for HER2 positive metastatic breast cancer with brain metastasis after trastuzumab therapy as systemic therapy.
Thank you so much, Ravi sir. We are obliged that you are here with us. Thank you so much, sir. We will quickly move ahead to the next panel today. The next, can I have the slides, please? Yeah. The next panel is on neoadjuvant approaches in triple negative breast cancer. Our moderator is Dr. Ashish Vijay Bakshi. I think he's there with us. Sir, you're there. Sir, you introduce the panels. You are muted, sir. Kindly unmute yourself. Yeah. Welcome all the panelists. I'll quickly move ahead. Thank you, sir. Sir, you are not audible. Yes. You are not still audible, sir. Yeah, the timer is started.
Can you hear me now?
Yes, now you are audible. Thank you, sir.
Can you enable my screen sharing?
Anita, please do the needful. Sir, we have 25 minutes, 24 minutes now.
All right. Can you see my screen?
Yes, sir.
All right. Okay. So let's move on to the panel discussion. So the panelists are Dr. Satyankar Gupta, Dr. Sri Gopal Mohanty, Dr. Sandeep Ganguly. These are medical oncologists. Dr. Manas Baisak as pathologist, Dr. Sudham Sadangi and Dr. Neha Chaudhary as surgeons, and Dr. Prakash Swain is a radiation oncologist. I hope everyone is there. Is someone not there? All right.
we are.
Okay. So a brief case. Actually, this was a 52-year-old female. She had no comorbidities. She had no family history of breast cancer or other malignancies. And she presented with a lump in right breast of about 4.5 centimeter. Clinically, there was no node. PET-CT didn't show any metastatic disease. And the histopath was IDC grade 3. And it was a triple negative breast cancer with a Ki67 of 29%. So the first question to anyone actually can take it. How do you define triple negative breast cancer? I think there has been some discussion in the previous sessions also. So how do you define triple negative breast cancer in your practice? You take a cutoff of less than 1% for ER or take a cutoff less than 10%? Dr. Sri Gopal?
Yes, sir. So we consider ER is less than 1% is we consider negative. So the ER low subset still we don't consider is in triple negative so far in practice. So ER less than 1% we take it negative.
Okay. Anybody has a different opinion?
So basically, ER less than 10%, we would in our minds treat it like a triple negative biology. However, you would probably still add on some adjuvant hormone blocker. But basically, ER low also acts like a triple negative variety. So we do treat it more like triple negative.
All right. Okay. So we'll come back to this later on. Now, Dr. Manas, this question is for you. Like, what are the different subtypes of TNBC that you encounter in your practice?
Well, mostly what we get is the metaplastic kind of breast cancer that may be with the usual ductal carcinoma with a squamous differentiation or a carcinosarcoma or a different heterologous differentiation. All those metaplastic and a few percentage of lobular as well. And unusual adenoid cystic and all that is there. Once in a while we see those cases, but mostly metaplastic and medullary kind of tumor.
So you are stressing on metaplastic. Actually, how common is metaplastic in your experience?
Yeah, we get metaplastic as compared to others. Medullary, yes, medullary is more commoner than metaplastic, in fact, which we call it as a basal-like morphology that we talk about with very aggressive morphology, lot of lymphocytes and all that. So we get that with a triple negative feature we get.
All right.
We expect a triple negative presentation in that.
All right. Do others have the same experience? Metaplastic, in my experience, actually is not very common. I would say less than 1%. Like, although this study that I have mentioned, it has mentioned triple negative 8%, but I don't see metaplastic that commonly actually.
I think, sir, this is about the metaplastic 8% among all triple negative they have mentioned. So as a whole, among the breast cancer, it is exactly what you said is less than 1%. So yeah, commonly it can be triple negative. Sometimes it can be HER2 positive also, less likely luminal type.
That's right. All right. So now the question to the clinicians is that both the surgeons and medical oncologists can take this, that do you see all the triple negatives in one light or you categorize them as low risk or high risk?
I take it as all one light.
Okay.
Sandeep.
So when you are treating in your practice, you will treat all of them in the same way, like whether it's a adenoid cystic type or a secondary type.
Adenoid cystic, we really do not know that what's the benefit of a neoadjuvant, because it can be the apocrine glands, but if there is a invasive ductal carcinoma with a triple negative in the receptor expression, I think I would do treat equally. adenoid cystic is a very controversial. We really do not know what's the benefit of the neoadjuvant or the adjuvant therapy. We do give sometimes, but the benefit for adenoid cystic is really not.
All right. So I think the important point that I wanted to drive here was that there is a wide variety of subtypes in triple negative breast cancer, and probably one needs to take into account the histologic subtypes also when we are kind of deciding therapy on these patients. So now coming back to the surgeons, Dr. Sudham Sadangi is there. Is he there?
Yeah, yes, I'm
So
here.
Dr. Sudham, maybe you can take this question that like, do you routinely put marker clips when you first see a patient with triple negative breast cancer before starting their neoadjuvant therapy?
As per our protocol, we decide whether the patient is, we are planning for a breast conservation surgery or sentinel lymph node biopsy. If the patient is willing and there is no contraindication of BCS or SLNB, then we should go for this marker so that we can remove post-neoadjuvant therapy, we can remove the tumor. And also for this sentinel lymph node biopsy, it is clinically emphasis there. And you are going, you stated FNAC and it's proving that this is most prominent node, then we should put a clip so that in subsequent after a neoadjuvant chemotherapy, while during sentinel lymph node biopsy, we will remove that lymph node along with the sentinel lymph nodes. Otherwise, if the patient is planned for MRN, then no need of putting marker because we are going to remove the whole breast and axilla.
All right. Dr. Neha, any different comment or different
No,
take on
no,
this?
I would agree with him, except that we still don't have the facility of clipping node yet in our institute. We still don't have that. So we're not doing it till now. We'd like to start it soon. Otherwise, same for the primary.
All right. Okay. Now, coming back to the medical oncologist, do you really need to treat every patient with neoadjuvant chemotherapy?
Anything more than 0.5, yes. And based on the age also. If it is a very elderly frail, 2 centimeter, we may go for surgery and this thing. Otherwise, more than 0.5 to 1 centimeter, ideally, yes.
Okay, and now one question that is from clinical practice. How commonly you come across patients where surgeon has patient is triple negative, surgeon has operated, and then the patient is referred to you?
In my previous institute, it was 10 to 15. In my present institute, I think almost 1.
So everyone you are treating them with neoadjuvant. So Dr. Neha, I can see you smiling. What is your take?
No,
Like,
no.
does
It's like a
anyone...
reverse. It's a reverse. Like
So,
it depends on practice to practice.
Okay, I'll just make 2 points. First, I don't agree that all TNBCs less than 0.5 cent or more than 0.75 centimeter need NACT. My cutoff would be say around 1.5 to 2 centimeter. More than 2 centimeter, I would send for NACT. Second is if the patient is in that category, I send all of them for NACT, and that's how it is in my institute. We don't operate upfront a patient that shouldn't be.
No, but like you are mentioning, even up to 2 centimeter, you will operate them first. Am I getting you right?
See if you look at data, the data for especially less than 1 centimeter T1A TNBC, the evidence for NACT is very controversial and debatable. So then I would say that still has to be established. In fact, there was a very nice paper by Mamtani in SCBC, where she has very nicely written that why all T1 disease, which is TNBC, should not need NACT. I would like everyone to read it, but I think that still has to be established. Maybe T1B I would be thinking, but T1A definitely not. I wouldn't send that patient for NACT.
Okay. But like if you see as these graphs from this
That is
this is from
predict
an article by
NHS.
Dr. Peter Schmidt actually. But even here also there is a 5% difference in T1A also. So I don't know whether we don't know whether we should be treating them also with neoadjuvant therapy.
Exactly.
All right. Anyway, let's move on. Now,
Sir,
Dr.
one point to add
Manas,
in that.
can you take this? What is the, like, do you routinely report on stromal tumor infiltrating lymphocytes in triple negative breast cancer when you are doing the histopathology examination?
Manas sir, you're there? So he was there.
Okay. Anyway, then let's move on. So basically, TIL, as we all know, has a good prognostic value actually. Important point here is that actually in this one paradigm study where they showed that those patients who had stromal TILs more than 75%, even without chemotherapy, they had an excellent outcome. So probably this may be a subgroup where actually they may not need even neoadjuvant chemotherapy if the stromal TIL is very high. But of course, this is kind of for discussion at this point of time, not something that is standard of care. Now, as we all know, based on the Keynote 522 study, pembrolizumab is the standard of care. So what is your take? Do you agree that every patient needs to be treated with a neoadjuvant immunotherapy?
So unless it is not metaplastic, sir, in invasive ductal carcinoma variant, triple negative, the data is saying that all gets benefited irrespective of PD-L1 as per the Keynote 522. So yes, all invasive IDC with triple negative breast cancer, if you are going for neoadjuvant, yes, irrespective of all.
So if you look at the survival curves here almost 75% of the patients without pembrolizumab are actually event-free at the end of 5 years. So we are overtreating a lot of patients actually. So we really do not know which are the patients which would actually benefit most with pembrolizumab. But yes, I mean that based on the evidence at this point of time, we are treating everyone with pembrolizumab.
Right.
Now, and as you rightly mentioned, irrespective of the PD-L1 status, actually patients are benefiting with therapy. Irrespective of the PD-L1 status also. Here again, like there was some discussion with regards to the carboplatin, those patients who are more than 65 years of age, even here the line of unity is crossing the bound one. So the confidence intervals are crossing the line of unity. So again, there is something in patients who are elderly where actually the benefit may not be seen with pembrolizumab or carboplatin. We something needs to understand that. Now,
Sir,
is any like there are a lot of biomarkers that are described in triple negative breast cancer to predict the response. Do any one of you are using these markers in your day-to-day practice?
not yet.
Not yet, not yet.
All right.
Sir, if you see the previous slide, sir, one point, sir, I want to add. If you see the previous forest plot, can you please show that slides? So based on the previous discussion that whether more than 1 centimeter we should consider neoadjuvant or not. Here we can see the forest plot. Here T1 or T2, you can see the hazard ratio for event or death is 0.51. It's quite better than the T3, T4. So if it's more than 1 centimeter IDC, high grade triple negative, still T1 more than 1 centimeter, still we can consider.
Right.
Just one more point here. In Keynote 522, now there were no T1 patients.
Yes, T1C. They were T1C and beyond, not
But madam is
T1A.
telling about T1A. So not T1A, T1B, at least T1C we should consider.
Correct. All right. So now coming to the discussion. So again, this discussion is more for the medical oncology. So I would like them to opine actually. Now, this is a meta-analysis of the various studies that have been done where actually the meta-analysis, they have shown benefit in both event-free and overall survival with the addition of immunotherapy. Now, but again, these studies, if you look at them, the Keynote 522, Impassion 031, JPAR-NUVO, and ISPY, they actually differ to some extent. And as you can see here, like where in Impassion, this was a negative study where capacitabine was allowed, as against that in Keynote 522, capacitabine was not allowed. So do you really feel that this might have made an impact on the outcomes of the two trials?
Yes,
so sorry, 9 minutes to go.
Yeah,
I think so. I think so.
Yes, sir. Yes, sir. This could have impacted.
I think so.
And also there is a difference between Impassion 031 and Keynote, that platinum was included in Impassion 031 and which is given like, the this Keynote trial, platinum was added. So it has given a PCR benefit irrespective of the PD-L1 status. Whereas in the Impassion, the platinum was not added. So PD-L1 positive tumors has a better PCR rate.
Correct. So I think even if you look at this, I agree with your point. Even neotrip, actually, there are no anthracyclines. And as you can see here, there is almost a 10-20% difference between what you are seeing in Keynote 522. So probably the carboplatin and the anthracyclines that are used as a part of protocol are also making a impact on the outcomes.
Yes.
Now, another question is that really, like in Keynote, they have given adjuvant pembrolizumab for 1 year. As against that, in the JPAR Neo, actually, they just gave 8 doses in the neoadjuvant setting. There was no adjuvant immunotherapy given. And here also, as you can see here, the event-free survival is 85% versus 77%, which is quite similar to 84.5 versus 76% in Keynote 522. So the question is that, do you really need adjuvant immunotherapy? What is your take on that?
So when there is a PCR, sir, still I'm skeptic to use maintenance. I'm not very sure. But in case of residual disease, still in triple negative, we need some maintenance. And if resource is available, immunotherapy maintenance, I will still prefer.
All right. So again, at this point of time, actually, we don't have a clear answer to this. So we would go by whatever is the published evidence. But yes, actually, trials are trying to answer this question. There is one trial called as Optimized PCR, which is looking at whether one needs to really give adjuvant pembrolizumab. Now, when you are giving neoadjuvant chemotherapy, what is the preferred chemotherapy? There are plenty of treatment options in neoadjuvant chemotherapy. So maybe Dr. Mohanty, you can take this. Like, what is the
I'm
chemotherapy
preferring
choice?
taxane and platinum-based protocols, up to 6 cycles.
So Ashish, Dr. Satyankar is there.
Yes, so
Sri Gopal is answering
Yeah.
everything, no?
So
Satyankar
Satyankar,
is there and
please
Sandeep is
please
there.
comment. What is your choice of
Yeah.
chemotherapy?
So I totally agree with the previous speaker. We can consider taxanes and carboplatin, but practically anthracyclines are a very important component of neoadjuvant chemotherapy. So my practice is I go with the paclitaxel plus minus pembrolizumab, followed by a dose-dense AC or EC or a weekly paclitaxel, depending upon the fitness of the patient.
And so say, for example, if you are giving dose dense AC or EC, how do you integrate then 3-weekly pembrolizumab? What will you do? Because your pembrolizumab will come every
No,
3 weekly and
because
your chemotherapy will come every 2 weekly. So how do you
if we are
integrate?
giving pembrolizumab, then we have to give only 3 weekly. But if we are not giving pembrolizumab, then we can give 2 weekly.
Okay. So again, I think this is one of the unanswered questions here actually on how one should do that. One of the recommendations here is that you can actually give pembrolizumab every 6 weekly. So then actually the number of admissions can be minimized. So this is one way of doing it. All right. So carboplatin, I think role has been discussed and there has been a lot of debate. All of you are agreeing that actually carboplatin should be included as a part of this thing. So I think we'll skip this discussion because already a debate has happened on this topic. Now coming to the surgical management, Dr. Neha and Dr. Sudham, how does neoadjuvant therapy impact your decisions regarding surgery in triple negative breast cancer? Like whether you recommend breast conservation surgery or MRM, like how do you make that choice?
Yes, we will recommend BCS because TNBC as such is not a contraindication for BCS. Only if it is a contraindication for BCS, then we will not do BCS. Otherwise, we will prefer BCS in TNBC. And regarding the TACUS, we have already discussed. If we are planning for a BCS in TNBC before neoadjuvant therapy, we should give a TACUS to the primary, and as well as if it is clinical N plus, then we will give a TACUS to the nodal. Management of axilla, if it is a clinical N plus disease before neoadjuvant chemotherapy, and it becomes clinically N0, then we can remove the tacker element with sentinel lymph node biopsy. And if it remains the clinical N plus, then we will do the axillary lymph node dissection.
So in case if the patient, like in this case, the patient has no family history, we have not done a genetic testing, but in case if the patient is BRCA positive, will you do a breast conserving surgery or MRM?
If genetic, it is not a contraindication for BCS. If BRCA positive is there, it is a relative only contraindication, not an absolute contraindication.
Dr. Neha?
Agree. BRCA positivity is not a contraindication for BCS, so it is okay to do a BCS even if it's a BRCA positive. Even though we would counsel the patient that there's a chance of a second time.
Okay. In terms of the management of the axilla, some of the questions that I had was that, like you mentioned about sentinel lymph node as per the ASCO guidelines and all that. Do any one of you are doing targeted axillary dissection?
So as I said earlier, I'm not doing. I think Dr. Sudham is doing it.
So
It
Dr.
is the
Sudham,
targeted axillary dissection is the same thing. We are providing a tracker to the clinically positive lymph node, which is proven by the USG guided FNSC, and we are removing that lymph node along with the other sentinel lymph node positive during the surgery. That is the targeted axillary dissection.
but clipping, as you mentioned initially, clipping of the node initially, are you doing that?
We have done 2 cases only, so not routinely, because the subset of patient willing for the BCS and not SLNB are very less number of patients. So we have done 2 patients with axillary lymph node clipping and removing that one.
Okay, another
And
difficult question.
both of them came out to be negative. So we have not done axillary lymph node dissection in both of the patients, and both are on follow-up only.
Okay, another difficult question is for both the surgeons. Yes, so are there any patients in whom you can omit surgery?
Thankfully, not yet.
ECOG 3 or 4. ECOG 4, I think. ECOG 4 or 5.
It's not good.
All right.
Otherwise,
Yes, so I think there is a lot of literature about vacuum assisted biopsy and defining PCR with MRI and all that. But yes, at this point of time, that is not something standard of care. Now, Dr. Manas is not there. Is he there?
Yeah, I'm here.
So, Dr. Manas,
Sorry.
how do you define pathologic complete response?
Yeah, there is a you mean to say a neoadjuvant response?
Yes. So, I mean, are you reporting on residual cancer burden in your
Yes,
practice?
we are doing it to the residual cancer burden with a formula that is being used by the MD Anderson
So the
app
Siemens,
that has been given.
Siemens publication, what showed the RCB you are reporting as per
Yes,
that routinely.
and we take care of yes, sir. We take care of the maximum time tumor dimension and the cellularity for the primary tumor and the DCIS component and the number of lymph nodes that are positive. It automatically calculates once you put that in the formula, that will give you the residual cancer burden calculation.
Okay. So Dr. Swain is there, Dr. Prakash?
Yes, sir.
So
Yes,
what
sir,
are your
I'm there.
criteria for offering radiation to TNBC patients? Are there any contraindications that you consider?
Yes, sir. With respect to this TNBC subset, the indications for RT, like post mastectomy RT or post BCS RT, remains the same with some deviations or some changes being there. And specifically, we know this basal type of TNBC. They seem to be radio resistant, so they haven't shown much response to radiation. But for non-basal types, they have shown good response. And one more thing is for all the node positive cases, including the N1s, have been considered for post mastectomy radiation therapy. And regarding this contraindications, I think the major contraindications are we should avoid the partial breast irradiation or accelerated partial breast irradiation. We have to treat these the entire breast and axilla if possible in TNBC cases. And one more thing is that in TNBC cases, even the elderly patients whom in hormone positive cases we would have avoided, we have to consider them here for PMR.
Okay. Can we have 1 minute more?
Sir.
So yes, the last question, maybe Dr. Satyankar, you can take this, that in patients who have residual disease post NSAT, what is your preferred chemotherapy? How will you decide between
Well,
capacity?
it depends. Yeah, it depends on the neoadjuvant combination. If the patient has taken pembrolizumab, then definitely I would give pembrolizumab plus capecitabine if there is a residual CA. But if the patient is germline mutated, then definitely I would like to add pembrolizumab plus olaparib.
Okay. And any option of combining capecitabine and olaparib?
I don't think there is any data to support. At
Is
least
there
I'm
any
not aware.
data of pembrolizumab, olaparib, or pembrolizumab capecitabine?
Yeah, I agree
No.
with that, but there are few publication, I think.
No, but there is
Maybe
no phase 3 trial, so I think
no,
if
there's no
data.
phase.
if
There's no
so,
phase.
if we are
So I
giving
think
pembrolizumab, we should give the pembrolizumab for the 9 cycles and stop. I think we cannot pick one from here and one from here and give.
Maybe circulating tumor DNA.
So I
may
think
guide us.
there are many questions that need to be answered with regards to the management of TNBC, and probably we'll have to wait for these answers coming up in the next few years. I think since we have run out of time, I would like to thank all of you for a active discussion, and thank you very much.
Thank you so much, sir. Thank you so much, all the panelists. Good discussion. A lot to learn in TNBC yet. Thank you. We'll move ahead to the next. Thank you so much, Ashish, sir.
Yeah.
So next we have the answers. First, before going to the quiz 2, we will declare the result of quiz 1. Quiz 1 was taken in the beginning of the session by Dr. Saurav Mishra, sir. So the results are being posted also in the chat box. I'll quickly tell the names. For question number 1, the winner is Dr. Ravi Shekhar Patnaik. Question 2, Dr. M.V. Chandrakant. Question 3, Dr. Mahima. Question 4, Dr. M.V. Chandrakant again. For question 5, there was no one who could answer in the right time, so nobody gets a prize money. Congratulations to all the winners. To keep it interesting, we'll go ahead to the next quiz before the concluding talk of the day. So a lot of participants, whoever have listened to the entire discussion, so much informative sessions today, will be able to answer the questions. You can answer in the chat box, Dr. Neha. So the first question for the day. So I'll just identify the false statement amongst the 4 statements given here. Based on Destiny 2, a Destiny Breast 3 study, trastuzumab DX is preferred second-line therapy on progression while receiving a taxane and trastuzumab in the first line. The phase 3 Cleopatra clinical trial has a better overall survival response, PFS and OS ratios. The role of pertuzumab in combination with trastuzumab and endocrine therapy has been explored in randomized phase 3 pertinent trial. And the last one is regarding a trial. Trastuzumab emestine has been considered for the past 10 years to be the best treatment options. We have a lot of answers here. Answer please. Next slide. So the correct answer is C. All the statements were correct. The only wrong thing mentioned was the pertain trial is a phase 2 trial. It is not a phase 3 trial. All the trials that is mentioned here were discussed today in the discussion as well. Next slide, please. So this has been very elaborately discussed today. The study design shown here for hormone positive, HER2 negative, high risk early breast cancer patients for study. Which is the study design? I can see a lot of correct answers. Is it Next Monarch, Monarch E, Monarch 2, or none? Very, very nicely explained by Dr. Amish, Dr. Saurav, multiple debate in the debate as well. Time's up. Yes. Interesting answers here. A lot of correct answers. So the correct answer is B. It is monarchy. This was in detail discussed almost in 3 of the panels today. I'll not discuss any further and go ahead. The next question is a 45-year-old woman presented with lump in the upper outer quadrant of left breast. Clinical staging was T2N0M0. She underwent BCS SLNB plus oncoplasty type 2. Final pathological report was T2N0M0. HER2 positive, hormone positive, HER2 negative with Ki67 14%. The risk prediction tool that is commonly used. There was a discussion on that also today. Which of the following is a false statement? Prevents overtreatment. Included in the
Asian Geriatric Oncology Society recommendations group, can be used in Ki-67 below or up to 14%. And the score is an independent prognostic factor for distance meds. Yes, a lot of correct answers are there. So I'm talking here about can assist. Answer, please. Next slide. So we can see Dr. Manjuri has very beautifully told everything for can assist. The only two things that I want to emphasize here, she has mentioned it is in the intermediate risk for Ki-67 from more than 5% up to or less than 30% in hormone receptor positive early breast cancers. So that was the wrong option given there. Correct answer was C. Next, adjuvant breast radiation therapy as a standard part of BCS can overtreat many women. Which study assessed the identification of women with localized breast cancer who can safely avoid radiation therapy after BCS using a preoperative MRI along with the pathological reports? So most of the studies are using pathological or genetic reports. Only a couple of studies have done pre-op MRI. And this study was published in ASCO and Lancet in 2024 January. Lumina study, Prospect study, IDEA study, none. Yeah, a lot of correct answers here as well. The correct answer is Prospect study. Next slide, please. So we can see here the Lumina study tells about the genetic and pathological response. Genetic only in the IDEA study, which has a 10 years follow-up also to avoid post-op RT in BCS. Using a preoperative MRI along with genetic is the most latest, and this Prospect study can be applied in future to selectively avoid RT in BCS patients. It was published in 24 January. Next question. So this picture, Ghanshyam sir is shown earlier in a lot of moderations. Which cancer? So she is Tahira Kashyap, Ayushmann Khurrana's wife. Which cancer she was affected with and what was the stage for which she was treated? Correct answers are there already. Yes, correct. So which type also? Which type and stage? There has to be two answers, and both the answers correct will get the award. So I think many people have answered almost all the questions correct. It was just a summary of what has been discussed today. And I hope everybody enjoyed. The results will be out after consolidations, after Ghanshyam sir's talk. We are running ahead of time, so I will quickly hand over to Ghanshyam sir. So thank you so much for giving the opportunity, and thank you everybody. Next topic of discussion is by Dr. Ghanshyam Biswas sir.
Please allow me to present my slide.
Sir. Anita, kindly allow sir's slide presentation. Over to you, sir. Thank you so much.
Yes, sharing, ma'am.
So Garima, you can see the slides, no?
Yes, sir. Yes, sir.
Yeah. So this is the last talk of the day. So COM-CAPC is a fixed dose combination of capecitabine and cyclophosphamide for treatment of metastatic breast cancers. So we are talking about a fixed drug combinations. So lot of hues and cries in 2016 when drug industry gears up for a fight on ban on the FDC. So Health Ministry banned almost 300 fixed drug combinations in different fraternity people in medical science. So few of them were the cough syrups. If you see the therapeutic categories, so probably nothing much was happening in the oncology space as compared to CNS, endocrine, and infectious diseases. And now, so what is fixed drug combination? So a combination of two or more actives in a fixed ratio of doses. So what is the rationale? So rationale is a reduced pill burden, so making it more convenience and adherence. So monotherapies prevent and thereby so resistance. And the various examples are like anti-tubercular drugs used for retrovirus and leprosy. So in the yesteryears, so if we talk about oral anti-cancer drugs, those are few. But today, in 2024, probably injections are less, So be it chemotherapy, be it targeted therapies, so all are into oral formulations. So do you all believe that there is something like oral chemotherapy? A metronomic chemotherapy has been now prevalent, and there is something called fixed drug combination chemotherapy. So cancer, we know now today that there are many cancers which are chronic disease. You need to treat them long, like a diabetic, hypertensive, or hypothyroid. So a change of strategy in the war on cancer. So what are patients' perceptions when you talk about oral therapy? So they prefer it, but the question is it going to work? And when they listen to the cost of a osimertinib, कि बॉस 10 टैबलेट का कॉस्ट 1,50,000 है, अगर महीना का खरीदते हो तो 4.5 लाख का है. Then they think, so why a crocin cost 10 rupees or a calpol cost 10 rupees and osimertinib cost 1.5 lakh rupiah for only 10 tablets? And if they get a PAP, so then 1 plus 2 PAP. And then if they are costly, then they think, will it get covered in the insurance? And everybody of us struggle getting most of these oral targeted therapies covered under insurance. The insurance people says these are oral pills, so there is no need of hospital stay, so they cannot be like a cashless. So what is your perception as a caregiver or as a skilled oncologist? The 4 E's. So are these effective? Is there a evidence, or is it because of an eminence-based treatment, or it is just an expertise? So what are the oral chemotherapy? So I mean cytotoxic, because there are many other oral like CDK4/6, the hormones are there in MBC space. So I'm talking about oral cytotoxic, that's cyclophosphamide, that's methotrexate, that's the most widely used is capecitabine, and there is also an oral vinrelvin. Unfortunately, that's not available in our country. So look at the chemotherapy, monotherapy, capecitabine monotherapy, efficacy and tolerability. If we put together all the trials that are available, the disease control rate with capecitabine single agent ranges from somewhat 30 to 70%. The bucket list of capecitabine toxicity you can see from starting from insomnia to a pancytopenia. So if you are giving your patient a standard dose 1250 milligram per meter square twice daily, 2 weeks on and 1 week off, I think less than 10% of our patients will be able to take, and it's difficult. So these are all those incidents of adverse events which are seen in more than 5% cases. So that's a hell lot of bucket list for a capecitabine toxicity. Effective drug, but that comes with a huge toxicity. So the takeaways for a capecitabine is that there are standard doses we hardly use, metronomic doses we many of us used, flat and fixed doses. Again, many of us are in the practice, especially in the elderly patients or fragile patients. Tolerability, there are hematological toxicities, non-hematological toxicities like nausea, vomiting, diarrhea, and the biggest problem is hand-foot syndrome, especially during the winters. Schedules, so there are patients on a continuous lower dose. There are patients usually on interrupt doses 2 weeks on and 1 week off. So when these patients are in long-term therapy, so I try to change them into 1 week on and 1 week off also. So partner, capecitabine can be given alone. Capecitabine can go hand in hand with other cytotoxics in place. So why capecitabine is a preferred partner? Because there is a single agent activity, unique safety profile. There are available drugs like Paclitaxel, Dosi, Cyclo, which actually activates the thymidine phosphorylase. And the data and efficacy with combined use of drugs, including capecitabine, also there in phase 1 and phase 2. So this cartoon shows that once capecitabine is ingested, it goes to the liver, then after several enzymatic process, it goes to the tumor tissues more than the healthy tissues. So this CYD, that is cytidine deaminase, and the other, so that converts this DFCR to DFUR. And DFR to the active 5FU, the most important is thymidine phosphorylase. So this cyclophosphamide actually synergizes by upregulation of thymidine phosphorylase. So that's how, so we are we are trying to combine capecitabine with cyclophosphamide and then producing a synergistic effect. So rationale for combination is that anti-angiogenesis and, as you said, cyclophosphamide upregulates intratumoral thymidine phosphorylase. So promising tolerability and activity and attractive all oral alternative. So if you look at now the clinical studies of capecitabine and cyclophosphamide combination. So there's a phase 1 study of cyclophosphamide of a capecitabine 829 milligram per meter square twice daily, plus a cyclophosphamide of 33 milligram per meter square again twice daily. So 2 weeks on and 1 week off. So is feasible, active, extremely well tolerated. Phase 2 study, the difference in tumor response suggests that there is a reasonable chance that you can combine CAP with cyclo, which is superior to capecitabine alone. So disease control rate 57% with capecitabine, and when you are combining, so there's a 10% jump in the disease control rate. Coming to another phase 2, the SOAK study, PFS, OS, and response rate outcomes with these combinations favorable with those of and the capecitabine alone. And then, so from this study, the flat dosing of oral agents was used due to the published data. So now another phase 2 of a metronomic capecitabine cyclophosphamide is effective for first line or second line MBC, especially a luminal A disease or TNBC. Luminal A who have already finished hormonal options and then TNBCs. So what are the existing data and challenges? So there were no randomized control trial, no PK data, no confirmation of synergism. Doses used were not metronomic and not an FDC at all. So no systemic drug development intent till the INTAS actually helped in this study. So then there was need of research. So this was the enclosed study which got published into 2021, and thankfully with our respected teacher, Dr. Sudhi Gupta, I was also part with many of our colleagues like Dr. Suresh and many others in this, you can see. So this was published in the Breast. So this investigational product, that is FDC of capecitabine and cyclophosphamide. So capecitabine was coming at 700 and 400, cyclophosphamide at 30 and 20. So these were 3 groups: dose level 1, which was the lowest, then dose level 2 was the moderate, and 3 was the highest. So this was the morning dose and evening dose. As you increase the dose level, so the number of tablets goes up from 2 tablets in dose level 1 to 4 tablets in dose level 3. So there were 2 parts of the study. In part 1, so 1:1, so 22 patients in each, and then the DCGI permission came in August 2014, and then 1:1 was there. So if the key selection, the standard key selection, so every of these patients were exposed to anthracyclines and taxanes. So those who are hormone eligible patients, so you have to give a hormone. So all CNS patients disease were excluded. And primary efficacy was to look at the best overall response rate. Secondary efficacy was to see a disease control rate which included stable disease and looking at the safety profile of this newer combination. So the enclosed study, as I said, the part 1 has 22 patients in each, and then we move to part 2 with 72 patients in each. So from part 1, we understood that the level 1, which was the lowest dose, is not contributing any benefit. So that's why the dose level 1 was removed. In the part 2, we moved with more number of patients, that is 72 in each, with dose level 2 and dose level 3. And we can see the median age was less because we see our patient population of breast cancers are less. And these were, so most of these patients, around 80% of these patients had a PS1. So the results of the intent to treat population, we can see, so with dose level 2 and dose level 3, so the dose level 2 probably was more better, though almost similar numerically, so dose level 2 was higher. So this was per patient population again, so numerically dose level 2 was higher. If you look at that hematological and non-hematological toxicities, so dose level 2 actually fared better than the dose level 3. So in regards to hematological and non-hematological toxicity. So compared with published historical data, so higher rate of disease control rate and better tolerability profile compared to historical data with similar combinations. So if I compare with the dose level 2 and 3, so in dose level 3, so hand-foot syndrome and neutropenia were much more, and as compared to the dose level 2, and subsequently, so dose level 2 in clinical practice has become more common. So these were compared to other studies. So it showed that this present study, that is the enclosed study, showed probably a better disease control rate and a better safety profile if you're using the dose level 2. So coming to a reality check. So at the end of this, so at times the clinical expectations are for a big celebrity star. So when the budgets are less, so I think this capecitabine cyclovus is an eligible combination, effective combination. Now we have a study to show expected toxicity is less and definitely economical. So looking at the drug delivery system for FDC, so there are multi-layered tablets, that is buy or try. There are compression coated, and there is a tablet in tablet and inlay technologies. So in this capsi, so they have preferred tablet in tablet. So this was, you can see the green one is the capecitabine, and so like in the liver bed, there is a gallbladder. So the gallbladder is the cyclophosphamide, and the liver bed is the capecitabine. So this tablet in tablet combination became a patent for this. So if you break the Comcapsi tablet, so you will see cyclophosphamide is there inside. So 1 + 1 2 is not seen. So 1 + 1 is more than 2. So 2 ka 2 5. So it is more of a synergistic effect of capecitabine and cyclophosphamide at a fixed drug combinations. So we know that world's most successful couple is aloo and piyaj. So this is what the capecitabine and cyclophosphamide do. And if you see the size of the tablet of a Comcapsi is much lesser than what is the usual side of a capecitabine. So this is the journey of Intas of Comcapsi. They started all in 2007 and then ultimately got the DCGI approval in 2020-21. So this is a DCGI approval letters, and these are 2 patents, US patents for this drug for their different formulation. So new kid in the block for many of your patients as a metronomic therapy. So Comcaps is there, which is supposed to be world's first FDC of capecitabine and cyclophosphamide. That comes as a 2-strength, 700 capecitabine with cyclophosphamide 30 mg and cyclophosphamide 400 with a 20 mg. So to conclude, so Comcapsi can be summarized as C stands for capecitabine, O stands for oral drug, M stands for MBC, C for a cyclophosphamide, A for anti-tumor clinical effects, patent for a particle size and tablet in tablet formulation. S is a synergistic effect. Yes, you heard it right, that yes, for 2 tablets in a 1 combination. So thank you for a patient hearing, and that was the last slide from my side. Thank you so much.
Thank you so much, sir. Wonderful discussion, and world's most successful couple summarizes the combination completely. So thank you so much, everybody, for the entire session today. We are running a little late. I will invite Dr. Saurav Mishra, sir, for vote of thanks. And thank you so much to all the moderators, all the panelists, and most special thanks to the organizing committee from my side. Saurav, sir, over to you. Thank you so much, sir.
So last 4 hours we have been here, and just to show 125 participants are still there. And if you see the chat box, you would see how informative all the sessions have been, starting from the quiz to the debates to the panel discussions. Everything has been top notch. So the third oncology breast cancer sessions have been really good. I thank everyone, organizers, the participants, and the people behind making this event a great success. Special mention for Garima. She has been taking on and involving everyone throughout the session. Of course, Ghanshyam Bhai need not mention. He has been the man behind these events. So once again, thank you everyone.
So thank you, Saurav. Thank you, Garima. So Garima was in a vacation at Gopalpur, but still she has joined. So thanks for that spirit. And definite thanks to all those people who are behind the scenes, Sambit, Anita, Rudra, Sonali, and so many people who are behind the screen. So we end the day 1 with maybe
Sir,
12 minutes late. And
sorry to interrupt, sir. The winners for second quiz, sir, you will announce.
So we'll come to that. So before we end that, so we'll have the prize of the second quiz. So tomorrow we'll have the second part of this webinar. So that will be on lung cancer. So tomorrow again we join at 5 to 9 p.m. So you'll have different faces all together. And so hopefully, Saturday will be a big bluster Saturday. So over to Dr. Garima for the quiz announcement.
Okay, sir. So thank you so much, sir. Thank you so much for everything, sir, for making this happen and hustling through everything. So I'll quickly announce the result of the second quiz. Anita, I request you to kindly put the names also in the chat box finally. So first question, the winner is Dr. Deepak. Second question, Dr. Saurav Kumar Mishra, sir. Third question, Dr. Santosh Kumar. Fourth question, Dr. Swamprabha Sundar Ray. And fifth question, Dr. Swaroop. Many congratulations to all the winners.
Thank you. Thank you.
Thank you, sir. Thank you, Saurav, sir, for saving so much time for us. I think because of your effort, we could finish by 9:15.
So you can see, so all the winners are starting from S, except Dr. Deepak, Dr.
Right.
Saurav, Dr. Santosh, Dr. Swamprabha, Dr. Swaroop.
So let's change the Deepak. He should not be the winner, actually.
Thank you, sir. Thank you so much.
Okay. Thanks a lot. Good night, everyone. Good night.
Good night, everybody. Thank you so much, sir.
So Anita, we can close.
Sure, sir.
Anita, Sambit, and everybody from the team, thank you so much for all the efforts.
Yeah, thank you. Thank you so much, ma'am.
Thank you, ma'am. Thank you.
Thank you, sir.
Thank you, sir. We'll leave, sir. Good night, sir.